implications of that in diagnosis. Okay, still. Can you make that a full screen, please? Okay, so molecular pathology is study of DNA, RNA, but also proteins in the cell. We can study this by a varied amount of tissue. You can use fresh tissue, you can use snap frozen tissue, FFP that we routinely use in clinical practice, but also with the advent of liquid biopsy, you can use a variety of body fluids. You can use saliva, you can use urine, you can use blood to study it. Also remember that people tend to think that protein study is not really molecular, but studying proteins by IHC is also part of molecular pathology. So comprehensive molecular testing has heralded the era of personalized medicine. There are potential therapeutic targets, diagnostic markers. It also provides insight into the biology of the disease hitherto, which was very difficult to surmise from looking only at the morphology. It helps guide treatment decisions. There are predictions regarding the response to therapy, prognostic indicators of risk. You can also monitor something like a minimal residual disease and monitor the disease activity. So genetic alterations may be at gross chromosomal alteration level or a gene level alteration. Now, even a single mutation at a gene level can cause cancer. So it's important that we devise techniques to study both of these alterations. So the generic target for molecular genetic analysis is a nucleic acid, be it a DNA or a RNA. Commonly, it forms the diagnostic target presents some form of a mutation within the DNA of the tumor cell. Now, this could take the form of deletions, duplications, chromosomal translocations, or point mutations. Now, tumors have different combinations of these alterations, which can lead to any kind of a malignancy. Now, these different combinations are the favored targets of molecular analysis, and those serve as an objective indicator of malignancy. Now, while two tumors may look fairly similar under the microscope, they can be quite different on a molecular level. And that's why analysis of the genetic makeup of a tumor is now a part of the precision medicine diagnosis. Genomic testing helps to identify mutations in the DNA of cancer cells that drive the growth of the tumor. With this knowledge, it is possible to selectively attack proliferating cancer cells using targeted therapies and sparing the healthy tissue. Now, all of us know that if you give chemotherapy, it's like a carpet bombing. So even the healthy tissue takes a hit. With the targeted therapy, the aim is to only target the diseased tissue, sparing the healthy tissue, so that you have a good balance that you can achieve. Now, some of the techniques that one hears are about, for as far as sequencing goes, you hear of Sanger sequencing, next generation sequencing. PCRs are of various types, the conventional PCRs, the real-time PCRs, the reverse transcriptase PCRs, fluorescence in situ hybridization, and next generation immunohistochemistry. So these are all part of the diagnostic armamentarium that the pathologist usually has. Protein analysis by immunohistochemistry, and I feel very strongly for it because I like to do that. So it uses the principles of antibody binding to proteins to determine the level of protein expression in tissues. You can have tumor-related proteins of interest, and these include tumor-specific antigens such as CA125. You have protein products of oncogenes like NKX2.2. Actually tells you if the tumor is a Ewing sarcoma or not. There are tumor suppressor genes at the retinoblastoma protein. There's a whole family of RB1 deficient tumors that you can identify by immunohistochemistry. There are tumor cell proliferation markers such as Ki67 and even enzymes. You can have succinate dehydrogenase or a fumarate hydratase deficient tumors, which you can pick it up by immunohistochemistry. Now, protein correlates of molecular genetic events can easily be identified by immunohistochemistry, and it's much economical and faster turnaround time. So these are some of the solid tumors where I'm going to kind of run you through. This is by no way a comprehensive list. You have brain tumors where the new WHO classification, practically everything like the HEMAT book is full of molecular events which define the tumors as endometrial tumors, which have molecular classifications, cholangiocarcinomas, which have But these are the ones that we currently use. So that's in lung, in colorectal cancers, brain tumors, breast tumors. And when I talk of BRCA is also used for prostatic cancers and pancreatic cancers along with ovarian tumors. Sarcomas, particularly gastrointestinal stromal tumors, have a immediate diagnostic therapeutic implication. In head neck tumors for thyroid, we can use the BRAF analysis for determining therapy, and BRAF again for melanoma. So lung cancer, everybody knows, very high mutation burden. So you have chances of picking up molecular events in that. And I'm going to take you beyond the EGFR AL cross. That's what everybody knows. So what are the gene fusions that you look for in lung tumors? That's AL cross, RET, NTRK, the FGFRs 1, 2, and 3, particularly the FGFR1 amplifications in squamous carcinomas, and NREG1. There are SNPs, indels amplifications such as in EGFR, BRAF, KRAS, MET, and HER2. Then you have the immuno-oncology treatments, that's PD-L1 and tumor mutation burden. So coming to KRAS, which in the Western population, the number of KRAS mutations is much higher than us. But KRAS is basically a driver mutation, and it is basically mutually exclusive with the main drivers, EGFR AL cross. So it basically works as a better negative predictor of response to EGFR TKIs rather than what EGFR mutations predict as a predictive factor. Also, with advent of newer medicines coming up, the KRAS G12C and the G12D specific mutations have small molecule inhibitors available now. So Tabrafenib is a specific G12C inhibitor. So these are some of the options available to our treating physicians. Now, BRAF mutations are also seen in lung tumors, small percentage, 2 to 4%. Half of them are V600E hotspot mutations. The rest are non-V600E. And you would need to do an NGS to identify them. They're usually associated with light or never smoker status, micropapillary histology, and more frequently seen in female patients, at least the V600E mutants. The non-V600E mutants are usually in former or current smokers and associated with poor outcome. The US FDA has approved Tabrafenib and Tramatinib for treatment of metastatic lung tumors, that's a non-small cell lung tumors, who have the V600E mutation. Coming to the MET exon 14 splice site mutations and the amplifications, both of these splice site and the amplifications tend to make kind of herald a better, kind of a worse prognosis for the patients. They're more frequently identified in females, elderly, and the non-smokers. As I said, there's an independent indicator of poor prognosis. They're observed in 3 to 4% of patients with non-small cell lung cancers. Highest frequency are the ones with the sarcomatoid histology. Remember, the MET stands for mesenchymal epithelial transition, so that's easy to remember. That's when the tumor becomes sarcomatoid. The MET amplification is another mechanism of MET dysregulation. It can be seen as a true copy number thing, or you can also see it as when you have the bypass mechanism. When you are treating somebody with EGFR TKIs, how does the secondary resistance develop? Besides the T79M and the small cell transformation, you can have HER2 and MET amplifications as well. Now, both of these amplifications and exon 14 splice site mutations respond fairly decently to crizotinib. So here's just an explanation of MET exon 14. See, the exon 14 codes for the intracellular domain, which leads to degradation of the MET receptor. So when there is a deficiency, there is a mutation in exon 14, a splice site mutation, what happens is the receptor cannot get internalized or degraded. So what you have is a constantly active MET receptor. And when there's an amplification, results in increased MRA and MET protein overexpression. Again, this leads to bypass mechanisms and a constantly active receptor. Between how do you identify these? There are various modalities. IHC is not a good way to do that. FISH for MET amplification is the preferred choice, but if you have to look for the splice site mutations, you need to go for NGS. Between the NGS, it's preferable that you do RNA-based NGS detection over a DNA-based platform. The trade-off here is that you may not always get a good quality RNA. So if you don't get that, you might resort to a DNA NGS, but the RNA NGS is preferable. Likewise, for a RET fusion in non-small cell lung cancers, your RNA NGS is preferable. The most common fusion is the kinase family mutation, gene partner, that's a KIF5B. Also, you can get CCDC6, that's the other fusion partner. Now, typically, RET fusions are also independent. They're not seen with the primary fusions, primary mutations such as EGFR, AL cross, BRAF, or KRAS. Again, RNA NGS, just the way that you do for ET, is more preferable for RET fusion detection. Coming to HER2, it's slightly different than what you see in breast tumors. You typically find exon 20 insertion mutations, and that's most commonly as a 12 base pair insertion. It causes duplication of the amino acids 5VMA at codon 776. And therefore, you need to use NGS. You can't use IHC or FISH. So that's a strict no. What you do for breast tumors or anything, colonic tumors, that's not what you do here. Now, these tumors with the HER2 new insertions, or rather the duplication insertions, have worse survival outcomes compared with other patients. About half of them tend to have CNS involvement also. Also, remember that they do not respond to the trastuzumab monotherapy. They'll need a combination of drugs, which includes afatinib and neratinib. Now, NTRK fusions, the reason that they are in news is because it's a tumor agnostic indication for NTRK fusions. Likewise, a small proportion have been detected in lung tumors as well. They're not limited to squamous or non-squamous, seen in both types. You can also get it in neuroendocrine tumors and independent of gender and smoking status. There are drugs called entrectinib and laroretinib, which are very highly selective NTRK inhibitors. The frequency, because of its so much less detection, ranges in literature from, say, 0.1% to 3%. Most commonly, you find them in NTRK1 and NTRK3. Now, these have been described in both the genders with wide ranges of age and history of smoking. Now, clearly, as an individual test, it's not going to stand a great chance of pickup. So, as a part of a broader NGS panel, it would make sense. But pursue NTRK if it's a fusion negative, primary fusion negative lung adenocarcinoma at least. There are secondary resistance mutations which develop T7 and TM is very well known. But you can have bypass mechanisms. So as I said, HER2 new amplification or MET amplification could be one of the reasons for that. One of the other things is small cell transformation. So at when you have a recurrence or when patient is on TKI and there is a progression, it makes sense to actually biopsy it and not go for a ctDNA straight away, because you might be easily be able to identify the small cell transformation and you don't need to then do a molecular analysis. But there's also tertiary resistance. People who are on osimertinib, which is a T790M specific inhibitor, can get C797S tertiary resistance as well. So NGS would be the way forward for most of these things. Now, upregulation of NRAG1 has also been described as a mechanism of resistance to ALK inhibition in non-small cell lung cancers. So again, if you do a comprehensive NGS analysis, that's going to be useful. Now, liquid biopsy, well, it has a role. It's not that it doesn't have a role. It has a potential to improve patient care. Its immediate implementation in the clinic, though, is justified in a number of therapeutic settings, such as at the time of relapse when the tissue is inaccessible. Now, given its significantly lower overall test sensitivity, liquid biopsy is unlikely to replace tissue diagnosis currently. Identifying fusions is kind of challenging because you have so much less tumor material to start with. So you need a very high depth of coverage to actually identify that by liquid biopsy. However, it will complement tissue assessment in a combined approach, mitigating the limitations associated with each one of them. So when you do not have access to tissue, liquid biopsy can act as a substitute. Or if you know the fusion, then maybe it's just easy to evaluate it as a residual disease monitoring. So NGS has the potential to currently detect SNPs, small indels, copy number alterations, gene fusions. It reduces the sequencing cost per gene. There's a better representation of tumor heterogeneity. There's more sensitivity vis-a-vis single gene assays. One thing that you need to remember is that NGS comes with its baggage of problems. It's not very simple. Speaking out an NGS is very easy, but there's a question of result complexities. There are germline variants that you will come across, and you need to do a normal, tissue sampling at that time. Accurate understanding of the reports, even for pathologists who don't do it, is a challenge. Bioinformatics is quite complex. There are also limited number of approved drugs for a lot of these, things that will churn out. So it has its challenges. A limit of detection of NGS is dependent upon the percentage of viable tumor cells that Dr. Trupti just very eloquently mentioned. Now, the tumor content, as a rule of thumb, should be 2 times the limit of detection. So if your limit of detection of a test is, say, 5%, you need to have at least 10% of the tumor content, viable tumor cells in the tissue. And for formalin-fixed paraffin-embedded tissues, the desirable depth of coverage should be 400 to 500x. In practice, you get anywhere between 300 to 500x. Now, switching across to colorectal cancer treatment and molecular interrogation, So today, the treatment algorithms for colorectal cancers include evaluating for all-RAS analysis, also for HER2 and for mismatch repair proteins. In addition, NTRK fusions and TMB are the new biomarkers that one needs to look at. Now, liquid biopsy in colorectal cancers is also gaining traction because sometimes when you want to monitor the patient who's on anti-EGFR therapy to understand if there's a resistance being developed. So this is something that all of us know, that people who have KRAS mutations are unlikely to respond to anti-EGFR therapy. But about 1/5 of those ones who are non-mutated for KRAS also do not respond. They tend to have mutations in NRAS or BRAF. So you need to do an extended RAS testing, which includes BRAF as well. Now, mismatch repair analysis can easily be done by immunohistochemistry. As a name suggests, basically it repairs the mismatches. So any kind of mutations in these mismatch repair proteins leads to mutations. Two things. One, you get is missense mutations, because think of it as a proofreader in a textbook or any other books, and you don't do a proofreading, you'll get all garbled messages. When you get garbled messages, the proteins are not transcribed, so you get missense mutations. Also, it leads to elongation of microsatellites. So that's called microsatellite instability. Once you have this instability, it leads to frame shift mutations in the coding regions. So the proper protein is not transcribed. So if it affects the regions where there are tumor suppressor genes, the tumor suppressor gene will not be properly transcribed and it will not do its job correctly. So here's the flow where you have errors in DNA replication, which are fixed by MMRs. And you can see that light thing there. If you have a mutation there, it leads to instability in the coding region of the genome, leads to global changes in key proteins, which lead to cellular dysregulation and leads to carcinogenesis. So some of these are not always sporadic. A proportion could be germline inherited, and they are associated with the Lynch syndrome. Why do we need to know and identify Lynch syndrome? It's only important in the patient because they may have secondary cancers, but it has implications for the family members as well. So it's important to identify the Lynch syndrome also by the germline testing. So this is, I get a lot of these questions from a lot of our treating colleagues. What is MSI high, low? So when you do by PCR, it's called MSI high because you test for 5 markers. And if you have more than 3, it's called high. On immunohistochemistry, it's called deficient MMR. And if it's MSI low or stable, that's 1 or 2 marker, by PCR, it's called proficient MMR or MSI stable. Now, also tumor MSI high status is prognostic. Patients with early stage colorectal cancers, they have a better prognosis than those with the microsatellite stable tumors. They are also predictive. Most of these MSI high tumors are excessively sensitive to the PD-L1 or PD-1 inhibitors. Now, currently, the FDA, the US FDA, has again given a tumor agnostic approval for Pembrolizumab, which is an anti-PD-L1 for any solid tumors having a high TMB or PD-L1 expression. BRAF in colorectal cancer basically implies bad. It's bad news if you have BRAF mutation in colorectal cancers. But unlike melanoma, this is enriched in AKT and MET mutations. So the anti-BRAF inhibitors do not work for colorectal cancers. Switching over to gastrointestinal stromal tumors, that's one of these sarcomas where there's a huge implication for molecular testing. So about 85% of gastrointestinal stromal tumors have mutations in KIT or PDGFR alpha mutations, which means that 15% are wild type and have driver mutations beyond this. Now, these are sensitive to TKI such as imatinib and sunitinib, but also you have drug resistance. Once you give these TKIs, you will also have secondary resistance mutations. So I'm going to focus more on these. What is the wild type GIST? The ones which are 15%, which don't have KIT and PDGFR alpha, they are clinically indistinguishable. They look the same. On immunohistochemistry, they will mark with KIT and DOG1. So you will not be able to identify them as a wild type. And these wild type drivers could be anyone's range from BRAF, V600E, could be having a NF1, it could be NTRK, it could be SDH, it could be HRAS, NRAS. Now these can only be picked up by molecular techniques, including next-gen IHC. So here's the graphic description of this KIT and PDGFR. So exon 9 and 11 are the hotspots for KIT. About 60% or 70% of the tumors are covered here. The rest 5% in exon 18 of PDGFR has a specific hotspot, D842V. These are all imatinib resistant, the D842V. So here's what I'm trying to explain. So 85% of the GIST, KIT, PDGFR will work well. You will give imatinib, should work well. 15% are wild type. And there are 6% of the PDGFR 842V, the D842V, which is resistant to imatinib. So here's the catch. 20% of your GISTs whom you are going to prescribe imatinib upfront, 1/5 of your patients are not going to respond to imatinib. because they will not have the driver mutation. Therefore, genotyping of this GIS is very important. Not only for that, it all depends where the mutation is. If it's exon 9, it requires a higher dose of imatinib. If it's on 11, it requires lower dose. You can also have resistance mutations. So unless you do the genotyping, you will not come to know once the patient is on TKI why the response has stopped. So these are things that you can understand. Pediatric and SDH deficient GIST appear to respond better to sunitinib than imatinib. So SDH interpretation by IHC is also important if it's supposed to be a wild type GIST. So I'm going to show you one case here. This is a 46-year-old female with a tumor attached to the greater curvature of stomach. And you can see this, and all the pathologists in the audience will agree this is a high-grade tumor. On the top panel, you can see that nucleus, whose ploidy must be infinite. I don't know what kind of a ploidy that must be. This is a high-grade pleomorphic sarcoma for all practical purposes. On detailed history taking, apparently the patient had a GIST and also taken imatinib, stopped taking the imatinib. In multiple tumor sections that we examined, we got some patchy positivity for c-KIT and a little bit for DOG1. This was actually a dedifferentiated gastrointestinal stromal tumor. When we did the NGS, it showed a KIT exon 11, 18 base pair deletion. But not only that, it also showed a mutation in exon 14, which is a secondary resistance mutation. So that's where it helps you diagnose cases. For melanoma and BRAF, again, if you have a cutaneous metastatic melanoma, if you have the V600E mutation, you can use a medicine called Zelboraf, and that's Vemurafenib, which is useful. About 50% of the patients respond to the therapy. That's an NGS IGV view of a melanoma V600E mutation. So can I take 5 more minutes of the lip? This is my last part of the thing, is about next generation immunohistochemistry. So these are novel immunomarkers identified by a gene expression profiling or protein correlates of a molecular event or lineage restricted transcription factors. So gene expression profilings would include NKX 2.2 and a MUC4, for example. Protein correlate of a molecular event such as INI1, ATRX, MDM2, RB1, SMAT4, BAP1. The beauty of all these markers, at least the protein correlates of a molecular event, is they are typically expressed by every cell. So when there's a loss of expression, that's very significant, and it's very heartening to pick that up. And then there are lineage-restricted transcription factors such as SAT-B2 ERG or SF1 or NKX 3.1, which help you determine the site of primary origin. And there are antibodies towards gene fusions such as SSX, SS18, NAP3, STAT6, or even TFE3 gene fusions. I'm not going to bore you with all of these. I'm going to take you through some 3 cases in this case. But before that, to understand that the cancer pathways include mutations, translocations, amplifications, or gain or fusions, methylation and deletions. So mutations can be picked up by loss of expression or abnormal localization. For example, you would use a beta-catenin stain if it's abnormally located to the nucleus. That's something which tells you there is an alteration in the CTNND1 gene. If it's a translocation, you can pick it up as a fusion protein IHC. If it's a deletion, again, it will show you as a loss of expression. If it's an amplification or a gain, just as you see for an HER2, you will show an overexpression. If it's a methylation, again, it's a loss of expression. So you can do with what we do for the MSI analysis. So I told you about the loss of expression, abnormal localization. There's mutant protein. So that's IDH1 that we use every day in clinical practice for gliomas. There's the H3.3 G34V that you use for giant cell tumors of bone as well. So I'm going to take you through 3 proteins. BAP1. BAP1 is responsible for deubiquitination of histones. And as a result, it's involved in protein transcription and cell cycle regulation. It's also part of the HRD complex, which along with BRCA1 helps in DNA repair. It's an established tumor suppressor gene. Now, mutations in BAP1 gene are associated with uveal melanomas, malignant mesotheliomas, renal cell carcinomas, cutaneous melanomas, and intrahepatic cholangiocarcinomas. The beauty of this is it leads to loss of expression, and that's very useful. So here's the intrahepatic cholangiocarcinoma, and we know that there are no specific markers for intrahepatic cholangiocarcinomas. Morphologically looks like a poorly differentiated cancer with a very sclerotic stroma, expressing CK-EMA, has a profile of CK7 positive. And there's another stain called HNF1 beta, which marks intrahepatic cholangiocarcinomas, but it's not very sensitive towards it. But here's the BAP1, and you can see on the lower panels that what is marking is the normal tissue. Some of them are endothelial cells, some of them are lymphocytes, but the tumor cells do not show any expression. So that means it implies that there is a mutation in the BAP1 gene, leads to a truncated protein, and therefore no expression. So that's useful. Now, here's what I'm going to show you. This is a pleural fluid of cell block preparation of a pleural fluid and very innocuous looking mesothelial cells. We face this problem every day. We don't know if to call it a mesothelioma. I'm going to stretch yourself and call it a mesothelioma on a cytology specimen or a cell block. And you can see it's marking with calretinin and EMA. EMA is usually not expressed by reactive mesothelial cells. But what's most interesting is the BAP1 there. There is a very conclusive loss of BAP1 on the tumor cells, and the lymphocytes seem to be marking with it. So here's what the BAP1 can help you make a diagnosis of mesothelioma, even on a cell block preparation, obviating the need for a pleural biopsy. SMAD4 is something, again a tumor suppressor gene. About half of pancreatic ductal adenocarcinomas show this SMAD4 mutation. Where is it useful is that if you have small biopsies and you don't know whether to call it chronic pancreatitis versus a pancreatic adenocarcinoma, it's very useful. Or in a MUO setting where you don't know where the thing is arising from. Because again, pancreatic cancers do not have some specific markers. So here's a omental biopsy which shows adenocarcinoma, CK7-19 positive, but you can look at the SMAD4, there's a definite loss. So this was a metastasis of unknown origin kind of a setting where the SMAD4 was very useful. Now here's SS18-SSX, everybody knows that's the synovial sarcoma fusion analysis. This is a monophasic synovial sarcoma showing you SS18-SSX nuclear positivity. All very good, very nice. But one would argue, what's the big sense? I mean, anybody can make out a monophasic synovial sarcoma. Yes, but here's what I'll show you. This is a soft tissue tumor in a 19-year-old male. This is a high-grade round cell sarcoma showing MYC2 positivity. Now, is this a Ewing sarcoma or is this a poorly differentiated synovial sarcoma? There are treatment implications. Ewings will have to go for chemotherapy. Synovial might go for neoadjuvant and then surgical resection. Here's the EMA, the TLE1 shows some dim positivity. NKX2.2 is negative and the INI1 seems to be retained here. So therefore, that would make it slightly difficult to call it a Ewing sarcoma. And here's where the antibody is useful. You can do this fusion protein analysis without resorting to an actual molecular PCR assay, and in a couple of days, give a right answer to your treating physician. STAT6 associated with solitary fibrous tumor. It's very sensitive and specific, a nuclear marker for SFT at all anatomic locations, regardless of the tumor morphology. Again, a very straightforward SFT in the pleura, which will mark with a STAT6, but its use is for this kind of a pleural-based tumor, which is very high grade. You can identify the mitotic figures in this. It looks like a very high-grade sarcoma. And what is this? The 34 is highlighting some dilated vessels. It's not very clear on this picture here right now, but there were no hemangiopericytomatous vessels. And when we did the STAT6, with the dim CD34, this was a SFT. So it's like a dedifferentiated or a malignant solitary fibrous tumor. The last thing that I would like to do, this is something that I've recently included in my armamentarium, is DDIT3. This helps you diagnose myxoid liposarcomas. The myxoid liposarcomas have a translocation 12-16 leading to FUS DDIT3 or an EWS-R1 DDIT3 fusion. Now, low-grade myxoid liposarcomas usually not a problem to diagnose. Histologically, it's a myxoid spindle cell tumor with a curvilinear branching vasculature. But the challenge comes when you have a high-grade myxoid liposarcoma. I'm going to show you both of them. How does it look? Also, important that DDIT3 antibody recognizes the N-terminal of DDIT3. So whatever be its fusion partner, the DDIT3 will be picked up. So here's a very standard low-grade myxoid liposarcoma in the thigh, that pulmonary edema-like spaces. You can see the branching vasculature. And on the extreme right is the DDIT3 nuclear staining. But here's a sarcoma that I'm going to show you. This is a 73-year-old male with a tumor in the thigh. It's a high-grade sarcoma, probably round cell. It's undifferentiated. It's very pleomorphic. But when we add more sections, look at the things surrounding this round cell. It's a very pale area. And here you see the interface of that. So that looks like a myxoid liposarcoma, which is transitioning to a round cell differentiation or a dedifferentiation in this case. That's where the DDIT3 is useful. You can see it's positive on the left in the low-grade component, but also in the high-grade component. So that's a molecular correlator for protein investigation, and you can pick it up. So here's what I wind up. Appropriate use of genomic profiling has supported precision medicine decision-making. It's offered new treatment for patients with cancers. NGS allows maximizing the identification of clinically relevant genomic alterations using a limited amount of tissue, reduces the time, cost, and energy, basically prevents misuse of the tissue. There's a growing knowledge of the molecular alterations of neoplastic diseases offered by NGS. Comprehensive testing is useful not only to identify the driver of alterations, but also to identify the biology of the cancer and the progression. Now, the complexity of NGS findings therefore necessitates some kind of a molecular tumor board, because not everybody knows everything about it. You need to have a bioinformatician, somebody who's a specialist in NGS, the pathologist and the treating physicians all sitting on the same table to identify. So, friends, this is the current state of our art. Pathologists have for long remained in the shadows and done the backstage work. The advent of personalized therapy and molecular diagnostics has thrust the same pathologists into the arc light now. They're coming from back right into the center of the table now. Future is exciting, challenging, the opportunities are for seize. Friends, prime time beckons. Question is, are we ready? We need to be ready for it. Thank you very much.
Thank you, Dr. Mehta. That
Thank you.
was really an awesome talk. And first, thanks to Dr. Tripti and Dr. Jay for giving us all an insight into such a complex matter and making it so lucid, actually, so that we could, even our residents could have understood. So can we have a couple of questions, quick questions from the audience, if there are any?
Thanks both the speakers for the excellent presentation. My question to Dr. Jay Mehta is that how much our labs are equipped giving the EGFR mutation report other than exon 19 mutation L858R, exon 21, like the rare mutation upfront, I'm talking not at the time of the resistant pattern, including exon 20 insertion mutation. Because drugs for these, what you saw like EGFR, L, Grothman, MET, RED, BRAF, HER, we have now the drugs for the KRAS also. We now have the drug for the exon 20 insertion mutation also. That is the first part. And second part is that ELK are now being treated upfront with the third generation drugs like lorlatinib or with the alectinib. And the pattern of the resistance is entirely different other than the EGFR, where we get the T790M in 50% or more of the patient. And the plethora of the resistance patterns are there. So how much we are equipped to report these things?
So most labs which are doing molecular analysis should be okay to do the EGFR, the part one of your question, so that exon 20 insertions would be part of the analysis there. At least the well-equipped labs. People who are doing very focused small panels may or may not be able to do the exon 20 insertions, but the other exons would be covered. The ALK resistance would require a comprehensive NGS. That's not easy to pick it up by a very small focus panel. So then you would have to resort to somebody who does a very focused molecular genomic analysis. So that would be my answer to that question.
When you do a PCR based test, you have specific exons, like a very targeted thing where you cannot identify. So you will have I will come to that cases in the panel. So in PCR, you will just say it is mutant and you won't be able to exactly delineate which kind of exon 20 insertion is there or which kind of exon 19. So for that, when you do NGS, and if your panel has ALK and a specific tyrosine kinase domain, along with the fusion, you might get some resistant mutations if it is DNA based panel. So that will be covered, but that requires like a targeted multi-gene gene panel for that. But most of the lab, even when they are doing small genes, your ALK, EGFR, and all these are included in the panel pertaining to lung cancer.
Any other questions? Thank you very much.
Thank you.
So we move on to the next session. So may I invite Dr. ML Yadav, sir? Is he there in the audience? Dr. ML Yadav? Dr. Devki Keswani? She is medical officer in charge, pathology department at State Cancer Institute, Pratapnagar, Jaipur. Dr. Ishita Gupta, is she there in the panel? Yeah, Dr. Ishita, she is a consultant pathologist and lab head at HCG Hospital, Jaipur. So over to the chairpersons to conduct the molecular tumor board and invite the moderator, Dr. Tupti Pai, to conduct the molecular tumor board.
Morning, colleagues. I would, without wasting any time, I would invite Dr. Tripti to take the next session.
So very good morning to all. So we had first two sessions where initially we had this pathology based, what are the requirements for a basic molecular testing. And then we had very nice talk by Dr. Jay Mehta on the molecular platforms. So now is the time we see how a molecular test and how its use is made in the deciding the patient's management. So this is what we call as molecular tumor board discussion. So I will be discussing 3 to 4 cases, and where here we'll see. So I would like to invite my panelists here. So Dr. Jay Mehta, Dr. Om Shri Shetty, she is the scientific officer at Tata Memorial Center, Mumbai, and Dr. Ajay Singh, he is a medical oncologist from TMH. This is so let's start with the cases. So what is precision medicine? I would like to ask this question to Dr. Ajay Singh. What do we understand by this term precision medicine?
Hello, ma'am. Precision medicine now means coming to means I'll just discuss in terms of lung cancer. So now previously we used to define lung cancer based on the morphology, whether it's small cell, non-small cell, and again non-small cells, commerce, non-commerce. Now we know that lung based on this molecular this molecular data, the lung cancer is now heterogeneous, either EGFR, ALK, cross. So now, based on this data, we are treating each patient not as a lung cancer, but based on the whether it's a ALK positive lung cancer or EGFR positive MET, NTRK. So from the evidence-based data where we are previously used to treat patients with conventional chemotherapy as a for whole lung cancer, now over this decade we are able to know that the lung cancer is very heterogeneous. So from that common pathway treatment, now we are moving towards the individual patient based on their molecular profile. So now it is like each patient of lung cancer is unique, not it is a lung cancer only. It is a unique patient who may have a any of the mutation, which is now almost 16 to 20 mutations we are aware where the targetable therapy are available. So these patients are now treated with the individual treatment, not only based on the conventional chemotherapy.
Yeah. So to simplify what Dr. Ajay is trying to say, so precision medicine is like with the molecular profiling, you will identify a particular target or a actionable alteration, and you will apply this actionable molecular biomarker for the selection of the most appropriate therapeutic target for that particular patient. Okay. So NSCLC is a paradigm of precision oncology, and now we are hearing there are n number of targets in early metastatic, all kind of tumors. So coming to the case one. So this is a 50 years old lady, cuff with weight loss in 6 months, initially diagnosed as pulmonary TB, as is seen in most of the cases from India. HRCT is raised a possibility of primary lung neoplasm, and PET CT scan was done, which showed a right lung mass 8 into 4 centimeter with hypermetabolic bilateral lung nodule. So Dr. Ajay, what is your next, what would you like to do with this?
So initially we'll do the tissue diagnosis to confirm it's a lung, means ISC with the NAPCIN and TTF1. Once we are confirmed it is a lung cancer, again, we will redefine again with the molecular profile. So we'll ask for EGFR cross or more important NGS.
Okay. So first we'll go with, it looks like a metastatic. So here you will be more interested in what is the biopsy diagnosis. So Dr. Jay Mehta, so whenever you get a lung mass biopsy, so what is like your approach in a metastatic setting?
So firstly, I mean, there is primary versus metastatic. If it's primary, then you're likely to understand whether it's small cell, non-small cell, non-small cell, depending on the amount of tissue, as you know correctly said. If it's less tissue, then don't try to waste it for doing a whole plethora of immunostaining, but very succinct immunostains like TTF1 and a P63 and get away with that. So that would be my approach. If it's metastatic, then you need to see if they've done some PET scan or some primary and accordingly use that antibodies accordingly.
So very important with the imaging and all, see if it is a metastatic to start with, or if it is a very small kind of T size. So when metastatic, molecular are must in such cases. Okay, so we have this adenocarcinoma, ACNR pattern. IHC was done is TTF1 positive. But as I said, if imaging wise there is primary lung, you see a very classical ACNR pattern, you may not do IHC and preserve the tissue for molecular. So any thing on adequacy you would like to mention?
Yeah, so as I said, it depends on what technique you're using. The limit of detection needs to be 2x, 3x, then the the amount of whatever is the limit of detection. So if its limit of detection is 10%, you need to have about 20 to 30% adequacy in the tissue. Tissue is the issue. So every department, every organization or hospital needs to have its own policies on how to do that. Like at our place, we get the imaging person to give us 4 different biopsies in 4 separate containers. So by per force, we make those 4 blocks. And depending on the tumor content, the maximum goes for molecular, the least one goes to IHC, and then for PDL1 and so on and so forth. The triaging is very important, but that's centric to your place where you work, but it depends on the molecular tumor board, how you decide to go for it. But yeah, adequacy is very important depending on the test that your lab is using.
So very important point, adequacy, no matter how many cores, please divide, embed in separate blocks. Even if the clinician sends you in a single sample, single bottle, please divide at your lab level and make maximum number of blocks. Reserve the tiny tissue for IHC and diagnosis, maximum tissue for, don't feel tempted to use maximum tumor content for IHC. Okay, so this case was additionally asked by the medical oncologist for biomarkers. So ALK PDL1 ROS was asked, ALK PDL1 negative. So what next? EGFR you will ask, right? So EGFR ALK cross PDL1. So Dr. Omshri, would you like to comment on this slide?
So this is a real-time PCR profile that is looking at. So we've looked, it's a kit based, so different companies have different combinations. So this is what is being done at Tata Memorial Hospital. So this is a Diatec real-time PCR. So you get COBAs, there are different companies. So in real-time PCR, you're looking for all the exons of EGFR. So this particular image that is shown here, it shows that G719X, 719X, exon 19 deletion, exon 20, L858 are all the predominant regions are covered here. So as you can see, the last one, there is a control mix. So control mix basically talks about how the quality of the DNA which is present. So there is an internal control and there is a like wild type control. So both are present. So that is a check that the sample is good. Then it talks about, you can see everywhere there are 1-1 peaks. So that is all again the internal controls for those particular regions what is being tested. That means yes, there is amplification is there, the DNA was there in this sample. Now if you can see at exon 20 insertion, there are 2 peaks. So that means that particular region has exon 20 insertion. So based on this particular picture, you can see that sample has adequate amount of DNA and this sample shows exon 20 insertion present. So this case is positive for exon 20 insertion and it is wild type for all the other regions which has been tested for.
So when you analyze 121.
I think the important part especially for the residents who are present here, that probably in the adenocarcinoma or lung cancer otherwise, PDL1 should be considered as the part of the initial IHC.
Yes.
Irrespective of whether it's even I will say SCLC versus NSCLC, because it has a therapeutic implication.
Yes.
So it's not only the TTF1 or NAPSIN or the P40, the PDL1 should be the integral part of that for the therapeutic.
I would just caveat here that one needs to wait for the primary mutations because
so once we have labeled it as the lung cancer
Yes.
primary,
Yeah.
that's why, because that part was the missing in the discussion.
because if you have any of the primary drivers, then the PDL1 takes a second backseat towards all of those. So sometimes PDL1 report is available faster than an EGFR, but it needs to wait for the EGFR at least to come before acting on the PDL1.
still
But I take your point, yeah.
Still, I will argue in favor of the PDL1 for many secondary tumor. If we know the primary, or by the time primary is being detected based on the PET CT scan or clinical radiological examination, or in a otherwise known patient since last 1 year or 2 years cured and now presenting with the lung mets. There are many tumors where the PD-L1 has the implications in the treatment. So that's why the antibiotic.
I would like to intervene here. So even if you you get PD-L1 in 2 days, and even if you get that 100%, you can't straight away start with the immuno. You will have to wait for the primary targets to be negative,
So that's for
because
the-
it will have an inferior response if you start.
Yeah, that's for the primary lung cancer. My another question is to the medical oncology colleague present here and from the Tata colleague. What is your usual approach for doing this NGS? Is the sequential you do for the EGFRL followed by the comprehensive panel, or a typical patient which ma'am have presented like female non-smoker adenocarcinoma, and there's a relatively higher chance of getting the some actionable mutation positivity. So you will go for the comprehensive panel, or you will go for the sequential panel.
Sir, actually, I have added such cases where I will be covering this. This is in case 4. So I will be taking with it. Okay, so point in real-time PCR. So sometimes you have this DITEC where you get to see these peaks and you need to decide. But in platforms like COBAS, you directly get a written report. Be very vigilant. What is the input material quality and what is the quantity? Because you will just get a like a printed report, positive wild type. So very important to check the tumor content and quality. When you have this kind of DITEC and all, when you are doing real time, you at least get to see the peaks and decide. Okay, now you get a report of exon 20 insertion. So Dr. Ajay, are you happy with it, or you need any other information before you start the treatment?
Exon 20 insertion, ma'am, again, it is it's a very heterogeneous subgroup among the 19 and 21. And in again, exon 20, if we go again in detail, it varies from 761 to 777. And we can see that early 761 to 65 response to our first generation, then 65 to 75 may response to Poziotinib or other exon 20 insertion related drugs, and 74, 75 again may respond to Apatinib. So I think we require more detail, because this amivantamab and other exon 20 insertion, exon 20 insertion related targeted drugs is not available in India, and we are having only first generation. So I think it is better to have a more details regarding exon 20 insertion.
Yes. So so when you get exon 20, you just get initial studies where like it is a heterogeneous group, and in general, like you know that it is likely be resistant, not like EGFR, exon 19 deletion or L858R, which has a good sensitivity to TKIs. Exon 20 is known to be resistant, but then later on studies showed that there are different kind of insertions, and which region it is affected, it will depend the sensitivity of TKI will depend on that. So when you get a real time, so this is like things that will be covered in the panel, but when you get the report, it will be just exon 19 deletion, which exon 19 deletion or which exon 20 insertion you won't be able to make out. So that is one thing you have to keep in mind when you see a real time PCR report. So as Dr. Ajay said, in-frame insertions in exon 20 is very heterogeneous. It is 3 to 21 base pair, ranging from codon 767 to 774, but you cannot be able to exactly delineate when it comes to real-time PCR. So NGS was done in this case. So Dr. Omshri, would you like to comment on the, first I will come to Dr. Ajay. When you get a NGS report, what difficulties as a medical oncologist or a clinician you get when you get a NGS report? Just if we hand over this report to you, what sense does it make to you?
So in this, ma'am, at least this is a fair report where at least minimum information needed, that wave frequency and exact location of the mutation, that 773 duplication is mentioned. But now in India we have multiple labs which are doing NGS, and patients are coming from outside where they don't have a standardized method of reporting. So that time they miss that missing the reporting of wave frequency and that specific location of the mutation. They just mentioned that EGFR exon 20. I think the first part we need the the standardization of reporting in, at least in our country, and I think that is
So
the
when you
most
see
important challenge.
mutation,
We
what
want
do you see?
reporting to be uniform only. So most thing that specific mutation, ma'am, that we in exon, at least in this case where exon 20 insertion, I'll be interested in seeing the where is the exact location of the mutation and what is the frequency of the mutation.
So Dr. Omshri, I would like you to comment on what is the basic NGS report? What are the bare minimal report components that should be there in a NGS?
So I agree with what Dr. Rajay just mentioned, that there is a lack of uniformity in reporting the NGS reports, as we have lack of uniformity in the kind of test and the panels that are also performed. But I would always stress upon that following the Association of Molecular Pathology guidelines, these guidelines are available right from validating NGS test and performing the test, as well as standard reporting guidelines are present. So the bare minimum requirement is the type of library that is being used for performing NGS, what was the panel detail, and the interpretation part should always cover depth of coverage. Like Dr. Jay mentioned in his talk, for solid tumors FFP, it should be between 400 to 500x depth of coverage. That is to give a confidence in the data. Yes, this data is not spurious. The amount of DNA or the RNA that has gone into it has been completely covered by the NGS panel, because we are looking at multiple genes over here. So at least they should have been read minimum 500 times to the entire depth. That do you mean by 500x? So here that should be the minimum. So in this report, if you can see, depth of coverage is 1339x, which means each and every region has been read those many times by the sequencer. So chances of error are very low. And then it talks about the gene name one should be given. What is the type of mutation, whether it is an insertion, deletion, in-frame, all those needs to be given. And again, as Dr. Rajay rightly pointed out, for exon 20 insertion, one needs to know what are the regions which is affected, which amino acid is affected, because based on that, then the treatment decision would be taken. So you need to mention which amino acid is getting changed. Then comes the part that is variant allelic frequency. Now, this is again an important aspect. That is the region which tells you that mutation that is detected, what percentage of it. So usual cutoff is it should be at least 5%. Like, there should be the mutation should be present in the sample. So here it says it is 51%. That means it is definitely a genuine alteration. Almost 51% of mutation is being detected. And what type it is, what exon. Then also there is a tier-based classification that is as per AMP guideline, which tells whether it is a pathogenic, likely pathogenic. So I think that's going to come in the next slide.
Yeah,
so,
you can see.
So this is again as per the AMP and the ACMG guidelines. So any alteration need to be put into these baskets. So tier 1, and basically these are the variants of strong clinical significance, which is associated with that specific disease where FDA approved drug is available. So then comes the tier 2, or this is called as likely pathogenic, which have a clinically potential significance. Now these alterations, say for example, ERB to gene amplification, which might be there in breast, but if it is there in some other entity, you would not disregard. You would still say, yes, it is likely pathogenic. So that will be a tier 2. Then comes tier 3, or the most notorious one would call that is a variant of unknown clinical significance. You know about it, but you don't know what this would add. There is not enough medical evidence or not medical literature. So you would put it in variant like tier 3 basket. Then comes tier 4, or that is called as benign. So there is nothing much. I mean, it is there in the total population. So this variant-based classification is extremely important in the NGS reporting.
So Dr. Jay, what is the platform do you use for your NGS reporting, and what cutoff for VAPs do you use?
So currently I use the Thermo Fisher S5. Just a comment on the variant allelic fraction. So you need to kind of correlate with the tumor content. Now, in this case, it's slightly on the higher side. If it's more than 50%, one has to start thinking of a germline variant. In this case, it's not applicable, but if this tumor content was 80%, then I'm happy with the variant allelic fraction of 51%. But if it was only 5% and you get a 51% variant allelic fraction, you need to start thinking of a germline variant. But anyway, that's not applicable for this particular case because this is an insertion mutation. Otherwise, it's not germline. But yeah, the cutoff, I would say that you need to do your internal validations, serial titrations, and see what is the bare minimum that it's able to pick up, and then it loses the sensitivity there. So with our system, I take it at least as between 5 to 10%. So at least 5%, I need to see the variant allelic fraction to be confident of calling it as pathogenic and actionable.
So whenever you are dealing with SNVs, very important point, look at the histology subtype. What is the tumor percentage? Mention that in the report in addition to what Dr. Omshri has mentioned. And then look at the variant frequency. I will come to that in the second case. So she has rightly pointed out what are the bare basic. So DNA based, with SNVs, you will write what is the VAP. When it comes to copy number variations, you will write what are the average copies per gene. When it comes to RNA based fusion reads, you will see what are the read copies of this. So all these points you should check. And before seeing whether it is a positive or negatively entirely, look at the gene panel. How many genes is it targeting? If it is RNA based, if it is amplicon based, you will have known partners in the panel. So even in that times, you might miss on some fusion. So look at very critically at what is the target panel. So Dr. Ajay, so coming to your exon 20 insertion, would you like to comment on this slide?
So, I mean, this showing that near this C helix group and around that, it was a 773. So means it gives us confidence we can think of starting Hepatic. So it may work. We have data where in the 773 and 774 reason we can have a targetable drug. So at least we are sure we can treat this patient.
Yes. So initial assumption that it is in general a very resistant. Now look at this, in a 761, 762 codon 763, they still have the sensitivity to first generation EGFR TKI. Whereas if you see the distal part like 772, it has Afatinib, and in between you have Poziotinib sensitive. So it is a very heterogeneous. And for this information, you will need NGS, and definitely you won't get this information when you look at real-time PCR. So patient was started on erlotinib. As expected, there was marginal increase in the disease. The patient was advised to start Poziotinib. However, the drug was not available and patient was continued on chemotherapy. But these are the points to be kept in mind. Coming to case number 2, this is a 66-year-old lady with low backache since 15 days. PET CT scan revealed a FDG avid metastatic mixed lytic sclerotic skeletal lesions with multiple lymphadenopathy with race CA19-9. So Dr. Ajay, so there is no primary as such, it is widely metastatic. What is your next, approach?
In this scenario, ma'am, where we are not able to find out the primary, and so based on the first thing imaging, we try to think of some provisional primary. Here, predominant disease in the thoracic region, so we may consider as a lung or breast origin, and we'll look into the detailed ISC markers for lung and breast tissue.
Okay, so left axillary lymph node biopsy. Dr. Jay, would you like to comment on the pathology part?
It's positive for CD. Okay, so CD138 is also marks epithelial cell. So this is a carcinoma. GATA3 is weakly positive, and so GATA3 again is that way promiscuous, but otherwise would point towards a breast, but also marks pancreatic tumors and urothelial tumors. So with CK7, I don't know if there's something in the breast. That's what the first thing I would like to see and check. Oh, so you said it is negative for ERPR and R2D. Endoscopy was on. Yeah, so then this would, I would say, to investigate the breast otherwise, but otherwise it would be metastasis of unknown origin.
Again, a diagnostic dilemma, like you don't know where proper primary is there. You are widely metastatic carcinoma of unknown primary. So in a female patient, you get axillary lymph node adenocarcinoma. Your first thing is breast. But when breast is there, you have a mammogram, and then it cannot be missed. But lung, there are chances that primary can still be missed. So in this situation, GATA3 is a very non-specific marker. Weak positivity you get in multiple tumors. So look at the intensity. If it is strong, diffuse, very high chances of this being breast. But if you see it is very weak positive. Again, TTF1 negativity doesn't rule out a lung primary. 10 to 15% cases might have TTF1 napsin negativity. So these are the cases where you will raise a possibility of this or this being metastatic, primary sites, and you will ask for a detailed radiological correlation. But as Dr. Ajay said, there was no, and they will suspect this as a lung primary. So with lung primary, what next do you want?
Now, we are frequently seeing this CK7 positive lung cancer who are napsin A and TTF classical markers are negative. So we definitely go ahead with the further molecular testing with the EGFR all-cross, or more important NGS-based method for detection of defining this tumor as a molecular-based method.
So this was done, asked for EGFR mutation. It was negative. So next you will need a NGS. So Dr. Omshri.
So based on this report, this is PIK3CA exon 9 alteration, that is glycine 546 lysine. So the variant allelic frequency is quite low than what has been detected. So it's a little suspicious over here, because though the depth is pretty good, so I would like to go for an orthogonal validation also if it is present, and then carefully I would do the tier-based classification.
Okay, Dr. Jay, your approach in this case?
I think it's too low of variant allelic frequency for my comfort, and I don't think it's actionable in any case. So I don't know.
Dr.
would
Ajay.
put it pass.
For me also, ma'am, looking at the variant frequency, it is very low, and we don't have much data to target these unknown primary. And her ERPR was also negative. For PIK3CA, at least we need.
What if this was a breast cancer?
In breast cancer, again, ma'am, looking at the frequency, we have not given the targeted drug in the first line at least.
So here there is a.
ERPR was negative.
Mhm. Exactly, that is why I'm saying that primary is unknown. You don't know. So if I tell you this was a breast cancer and with this kind of VAP, what?
So again, in first line, we have not targeted this mutation. Only after the exhaustion of standard therapy, we may at the end consider the PIK3CA diet. But at this variant frequency, we will not target in the upfront.
Okay, and if it is lung, so definitely.
For definitely not. We have treated with some patients, but they are not showing any response.
Okay, so when dealing with low VAP, so I would first suggest that look at the tumor percentage, how low it is. If for this given case, it is like 50-60% tumor percentage, and with this low VAP, definitely don't consider it. But if I tell you that tumor percentage starting is very 5 to 10%, at least give it a thought. Like canonical mutation, typical exon 9 PIK3CA mutation in breast with 5 to 10%, you can still consider it if you have exhausted all your standard. Do you agree with this, Dr.
Yes,
Ajay?
ma'am. After exhaustion of standard therapy, we make.
You can just don't disregard looking at the low VAP. Consider certain like what is the primary, what is the tumor percentage. That is the point I would like to make a note of it here. And like this is not, if it is something, and like Dr. Omshri said, orthogonal validation. So now for orthogonal validation, don't use platform like Sanger sequencing, whose sensitivity is like 15-20%. Here you want to validate the VAF of 3.1%, go for real-time PCR or the like platforms which has very high sensitivity. So that is again one thing to be kept in mind. If this was like 20% and you just want to then Sanger sequencing and all is fine, but low VAP, use real-time PCR. So tier, so will it will the site of Dr. Jay, will the site of primary affect your tier reporting here?
No, for example, yeah, if it was as we discussed in the appropriate setting, the breast, it would make some sense, but for lung, I would let it pass. And
Okay, but if now here we don't know the primary, so what will you do in tier based reporting here? Will it
No,
affect it or will it not?
I think we need to know, right? It has to be in the context. So I don't think we can put it a standard tier classification if we don't know the appropriate context to it.
So definitely in all cases, you can't go away with all the rules and all the guidelines. There will be always some caveats. And these are some of the cases which really have this diagnostic dilemmas. So patient was started on this chemotherapy and patient progressed. So case 3, 65-year-old gentleman, no addictions, complaints of cough since 3 to 4 months, history of weight loss, CT scan 13x8 centimeter right lung mass with bilateral lung nodules, metastatic, so widely metastatic. Again, lung adenocarcinoma, lipidic acinar pattern, napsin. So here comes the question, like in a particular scenario, how do you decide whether upfront NGS versus stepwise? Coming to your question, someone was asking from the audience, I guess. I mean, now this is what you wanted, right? Like upfront NGS versus stepwise. How do you decide for a particular case? So, Dr. Ajay.
So now again, ma'am, we are aware that this tissue gets exhausted by stepwise testing. So my preferred approach to upfront NGS if cost is not an issue, and there is no urgency. Means patient is not much symptomatic. If patient is mildly or asymptomatic, I'll wait for the NGS report. If I'm thinking upfront patient is symptomatic, we need to target the patient at the earliest. Then I'll go for stepwise. Otherwise, my preference is to go for NGS so that tissue should not get wasted.
So there are multiple factors, like what is the condition of the patient? If patient is very serious, then
we'll ask for EGFR at least ALK cross ISC, because that way we will get in 24 to 48 hours, so that we can, and we know that ALK and this EGFR, these drugs works in 48 hours. We have clinically in clinics we are seeing in 48 hours patients becoming from PS4 to PS1. So we'll need at least ALK ISC or EGFR at the earliest. If asymptomatic, then obviously we'll wait for the NGS.
If asymptomatic, if finances is not an issue, if patient is affordable for the targeted treatment, so there will be multiple factors. There is no single answer like you go for upfront NGS or a stepwise, at least in our country as of now. So if patient asymptomatic finance is not an issue, definitely go for upfront NGS. Otherwise, if you see molecular targets like EGFR and all in our population, 50 to 60% cases will be covered by this. So if it is an emergency, you can ask for EGFR and you can ask for Alcross PDL1 by IHC. So reports you will get by 3 to 4 days. So EGFR was wild type in this case done by real-time PCR. So then Ross was asked by FISH. So Dr. Jay, would you like to comment on Ross testing in general?
Yeah, it's very low frequency alteration in lung cancer. So, I mean, at least we do a IHC first, and then if it's positive, we need to confirm it by FISH. But here it's already been confirmed by, yeah, it's FISH for us on the rearrange. So yeah, so then that's
So
the gold standard. Yeah.
So IHC should be used as a screening test. So you will see always in literature, there are cutoffs for H scoring like more than 150, more than 100. So any positivity will be positive. So no matter H score is 5 or 10, you have to ask for orthogonal confirmation reflex testing like FISH or NGS. H score being 100 or more than 150, there is a high probability of this being Ross gene rearranged. So don't take that like H score of 150 is only positive or H score of 100 is only positive. Any positivity is positive and you have to give a benefit of doubt and ask for reflex testing. So FISH was done in this case and it is showing rearrangement. So what is the criteria for calling a FISH positive, Dr. Jay?
Actually, I don't do the FISH, so I
Okay,
don't know
okay.
about that.
So on FISH, we say we take a cutoff of 15% and you see how much are the signals split. So you have, it is a break apart probe because you are not interested in knowing what is the fusion partner. You will just see if it is rearranged or not. So you will see break apart signals more than 2 signal diameters away. And when it is more than 15%, you will consider this as positive. So ALK-MET was done, it was negative. Patient was, so your first choice for Ross rearranged?
Nowadays, Crizotinib we are using. Otherwise, Entectinib is the first choice, but we are not available in India. So our first choice is Crizotinib.
So anything, any additional test you want before you Ross positive patient, before you consider Entrectinib?
MRI brain we see, if it is MRI brain is showing a metastasis, this is gonna, we'll prefer to use Entectinib only because it is available on compassionate basis. If there is no brain mets, then we are fine to use Crizotinib.
Crizotinib. Okay, so you have to look for brain metastasis, and because Entrectinib is preferable because of this increased permeability. So patient was started on Crizotinib and response evaluation scan shows progression on Crizotinib. So what next?
So here, ma'am, on progression, we'll preferably plan to do a rebiopsy to see whether there is any resistance mechanism was there and whether that resistance mechanism again targetable or not. And if we get something targetable again in the rebiopsy, we may consider again targeted or we'll start with the chemotherapy.
Okay. In EGFR, we do this, but whenever in ALK fusion and ROS fusion on progression, do you start with a different line of treatment or you need a resistant mechanism here?
We provision because on progression, the patients are generally very symptomatic and these driver mutation tumors are now generally, whenever they progress in a symptomatic manner. So we can't wait for the all the reports. We start by the meanwhile interim as a chemotherapy, and after getting the rebiopsy NGS, we may then switch over to the therapy if we are getting any targetable. But on progression, most of the time they are symptomatic only.
Okay. So patient continued on chemotherapy. There was progression, increase in size of the lung met, and now there are new lesions in lung and new liver mets. So what will you prefer? You will prefer a rebiopsy.
Yes, ma'am.
So any role of ctDNA here?
ctDNA, ma'am, it is preferable, but right now I think in our country we are not comfortable with the method of testing, and we are not getting a standardized reporting from the ctDNA. But obviously there is a role to if tumor is not biopsiable or a patient is not willing, we are asking for the ctDNA, but we are preferably using a tissue bias method for doing the NGS.
Okay, so post EGFR TKI on progression, you can like there are requests for this cfDNA, but this is a case of ROS positive fusion. RNA fusion analysis on ctDNA not well established as of now. So it is preferred here to go for a tissue rebiopsy. So liver lesion is showing metastatic adenocarcinoma. So Dr. Jay, when reporting such a case on liver, what are the parameters from pathology point of view you would like to address?
Just to confirm that it's a MET, and not a new primary, and sometimes you can just do that by morphologic evaluation, but otherwise conserve the tissue for molecular testing because that's going to change the line of treatment.
Any comment on small cell transformation?
Oh,
Like,
yeah, so if there's a small cell transformation, EGFR, if people are on the EGFR TKIs, that's a well-known escape mechanism. If there's a small cell transformation, then that that's the reason for progression, and you can easily give that answer to your treating physician then.
okay. So any TKI patient post progression, you get a biopsy. Look at the initial biopsy. If pattern is same. If initial was like SNR pattern and now it is solid, mention every time the pattern. Like you will say adenocarcinoma, you will mention pattern. You will say if there is small cell transformation or not. What is the tumor adequacy? If it is very scanty, don't try to prove if it is from the lung case. You can say metastatic in a known case of lung cancer and preserve it for molecular testing. Now, as we know, patient is already on progression. The answer here is NGS. So it is not like 5 to 10%. You should have at least 20 to 30%. So keep all these things in mind. And next molecular testing, Dr. Omshri.
So NGS has been done on this.
Okay, you are not able to see. So you have RNA CD74 ROS1 fusion.
So on this report, yeah, it's been mentioned like it's a combination panel. So again, as I already mentioned, you need to mention what all genes you're looking at. So it's a DNA RNA combination panel. So again, depth of coverage and the quality of the data, everything is mentioned. So, and then here the ROS.
ROS 2032GR. This is
That's a
DNA.
resistant.
I will dictate. So fusion reads are 38, CD74 ROS fusion.
Fusion reads are there. Okay, and what is the total?
38.
So 38 fusion reads are, so that means the fusion is already retained. I mean, what was detected in the primary is also here. So that means this just substantiates the fact that this case is still harboring the ROS fusion. And also, what is the total read count? Has it been mentioned?
No.
Okay,
This is
so
not.
when a NGS report is there, when the RNA fusion is being mentioned, so it is also important to write the total read counts. That means how many how many total RNA reads have been read. And in that RNA reads, how many fusion reads have been read, like in both the fusion partners, because unlike FISH, NGS report tells you the exact fusion and what are the fusion partners. So here the ROS1 fusion partner, how they have been read, and the total read count is 38. So as per the guidelines, anything more than 5 copies or 5 to 10 copies are considered to be valid in the NGS report. So here you have 38 reads in this case. So this fusion is retained. So in the DNA panel, I guess there is an SNV detected, that is ROS1. Can you just read out? I can't see that.
So there is a ROS1 DNA alteration G2032R, which is like 15%. 15%.
15%. So that's a resistant
Slides.
What is the VAF in that?
15%.
15%. So that is a resistant mutation. And so definitely this completely indicates the picture.
So Dr.
So-
Ajay, are you comfortable with 38 read counts?
Means at least in upfront setting and then relapse setting, the scenario is very different. Where in upfront setting, you was thinking of the VAF of 5 and more is significant. And again, relapse setting, I am thinking means VAF less than 5% is also okay to know the resistance mechanism. In this scenario, ma'am, 38, I think it is fair to.
So you mean if it was not, I mean, if it was treatment naive, 38 is not enough?
Enough, ma'am.
So you are comfortable with
Yes,
it.
ma'am.
Dr. Jay, what cutoff do you use when you deal with fusion read counts?
So RNA is always a challenge. I mean, 38 I would say is good. And particularly in this setting, when you already know there's a fusion and on the recurrence, I would accept 38 very gladly.
Yes.
Upfront, it all depends on what modality you're using and what kind of RNA quality metrics you had. If it was poor, then you'd like to bring it slightly down, and there's certain amount of giveaway here and there. But in this case, yeah, 38, if it's a known thing, I would gladly accept it.
So RNA is very notorious for having very poor quality and very important when you deal with this. Sometimes you get very unknown fusions about what reads. Just be vigilant when dealing with fusion read counts. Coming to the read counts, 38 is fair enough. In guidelines, if you see more than 5 to 10% is fine. This is a known CD74 ROS1 fusion. But sometimes some cases will have 5,000 reads, some will have 1,000 reads. There will be always a query. Do you need to validate this with this? So no, even we have cases like 15 reads, 20 reads, we have done IHC on this and it very well correlates. So there is not an issue with read count being as low as 38%. NGS is very sensitive and this read count is fair enough. Now the advantage here is this is a RNA and DNA based. So with RNA, you got this fusion, which was already a known case. And with this DNA, you got a resistant mutation as well. So Dr. Ajay, you have this resistant mutation. So how does it affect your management?
Okay, ma'am, our targeted therapy will be out of the question. We will directly switch to our conventional chemotherapy because these patients also respond to chemotherapy well, but the response duration will be not well, but at least for a short period, they will have a comfortable
chemotherapy.
life. Yes.
Okay. So now this is like, so these are this is a very nice article on key consideration for comprehensive validation of RNA, where they very nicely said ki how many there should, when you deal with fusion read counts, what are the supporting read counts spanning the fusion? Okay, fine. So we have this DNA ROS resistant mechanism. So whenever a patient on TKI resistance is bound to happen, you just see whether there is target alteration or there is activation of bypass. So this G2032R is very well-known resistant mutation where it alters the ROS1 receptor so that the binding of drug is affected. And there are n number of drugs which are, but as Dr. Ajay said, patient was on chemotherapy, was shifted onto. So not every alteration that you get, you will have a target. So keep that thing in mind. Do we have time for case 4 or should I stop? Okay, fine. So case 4, 61-year-old male from Bangladesh, right chest pain. So chest, CT chest, multiple nodular lesions in both lungs. PET CT showed a 7x6 centimeter, multiple parents, so metastatic setting. Again, biopsy, adenocarcinoma, IHC positive, TTF1, CK7, P40. So Dr. Jay, so how many times you get this both positivity for TTF1, P40 and how do you approach? What do you label
No,
this case as?
There is TTF1 positivity that supersedes everything else. That's an adenocarcinoma because you can, a proportion of adenocarcinomas might express P63 or P40. So this is for all practical purposes adenocarcinoma. TTF1 is diffuse and strong. And here's where I think Dr. Somani was mentioning. So yeah, PDL1 has been done upfront and at least all the drivers so far are negative. And if you're not going to then do the comprehensive testing, then the PDL1 is actionable. Otherwise you wait for it, depending on the clinical situation.
So lung biopsy, it is not every time hard and fast that adenocarcinoma will be TTF1, squamous will be P40. There is always a overlap. Always TTF1 will take a front seat. Even if focal positive TTF1, P40 diffuse, it will be a adenocarcinoma with squamous differentiation. Distinct components of adenosquamous will be a adenosquamous. Otherwise, sometimes we have cases like you have focal and diffuse strong P40 positivity. Such cases are reported in literature. You will call it as adenocarcinoma, and such cases are usually rearranged for ALK So keep this in mind. Don't get confused like P40 also positive. It is very well much known in literature. So Dr. Ajay, when you see a PDL1 positivity, what all parameters you want to know as a clinician before you start a treatment?
A few months back or a year back, we were comfortable with this report and we started therapy, whether chemotherapy or chemoimmunotherapy if affordable. But now we are seeing our panel, we are using a COBAS 2, which is where we still see a few EGFR mutations are getting missed. So now I started doing NGS and we are seeing even we get additional mutations there which were made NTRK, and even in EGFR also we are missing with the present panel which we are having in COBAS 2. So it is now I'm preferably using NGS only before starting immunotherapy based on the positive PDL1. So I'll be, I think, better to do NGS and then decide whether to give immunotherapy or not.
Again, with positivity of PDL1, always mention what clone you are using, what is the platform of detection, what is the tumor percentage, what is intensity doesn't matter, but see to it that you write like if it is more than 1%, it is positive. More than 50% becomes strongly positive, where in absence of any other target, it can be considered for a first-line immunotherapy. So mention all this thing in your PDL1 report, what clone. So what clone do you use, Dr. Jay?
I use a 22C3 on the DACO machine.
Okay.
But yeah, as she said, it's very important to actually get the exact score. There are a lot of labs which, report it as the cutoffs, less than 1, more than 1, less than 50, more than 50. It's always important to write the exact score because tomorrow you don't know, some other factor will come into the picture. The clinical trial guidelines might change. So it's going to be useful to actually tell the exact figure. It's 36, write TPS 36. And then you can broadly say that, yeah, it's more than 1 and therefore, weak positive or strong positive, so on and so forth. So Yeah, she says clone the machine that you're using and the cutoffs need to be clearly mentioned in the report.
It is like a companion.
So that convenient diagnosis is only for Pembro. SP263, I think is more, you know, is that.
Yeah. So it's just the availability of the Ventana machines is more than the Daco machines. But even if you're using the SP263, even if you're using on the Daco machine, you still need to document that that's what you've done. That's the story, bottom line.
So not every institute will have the liberty to use or that much finances. So every time you have this laboratory developed test where you take a clone that is available for you. In lung, you use tumor proportionate score. You mention what is the clone. At right now in Tata, we got this 22C3. Otherwise, we are using SP263 only. So we are validating all clones now in lung cancer, and we'll get back to your answer. Like, so we will be trying this on Ventana platform. So it is said that 22C3 on DECO, but we will be trying it on different platforms and says. So this is a part of laboratory developed testing. Okay, fine. So patient was, so this is like Om Shri. Just quickly go through what are the alteration and.
So again, this is the NGS report which was done. So EGFR is completely wild type, like how Dr. Ajay was suspecting there could be other alterations in EGFR that is not there, but this case has ERB2 duplication. This is the most classic duplication between the amino acid 772 to 770, the codon 772 to 775 duplication. So it's written as indel, that is insertion deletion in that particular region. And you can see that variant allelic frequency is 24.8%, this spanning the exon 20. So this is definitely the tier 1 alteration. Also, along with that, you have a TP53 gene mutation of exon 7. So this can be safely put under the tier 2 basket. So I also would like to put emphasize on the EGFR mutations over here. So real-time PCR doesn't cover entire spectrum, as Dr. Ajay said. So for every 2 EGFR mutations detected by NGS, real-time PCR misses 1. So almost 50% of the regions are not covered, specifically for exon 20 insertion. So when we give EGFR wild type by real-time PCR, we might be missing many of those alterations that need to be kept in mind. So here in this case, its ERB2 amplification is there, and also ERB2 mutation is also present. So this particular panel, what we are using at molecular pathology at TMH, looks at the copy number variations, looks at the DNA alterations, RNA alterations. So we can see here that its copy number 15.1 is mentioned. So again, for copy number variation, our cutoff is anything more than 6 is considered as appropriate, and we call that as amplification. And here this case is negative for RNA alteration. So again, all the details have been depicted. So this is how a regular general NGS report should look like.
Coming to this real-time, very important point, also look at the platform like COBAS is known to have false positive exon 20 insertion. So whenever on COBAS platform, if you are using and you get an exon 20 insertion, please confirm it with any other real-time PCR
I would
platform.
like to add
Yes.
to that. I must say that, but I guess COBAS platform is that way being quite upfront and honest. They keep updating,
Yes.
like, when the particular lot was released, immediately they were there to ensure, put a mail to all the users saying that there have been instances of exon 20 insertion only detected, which is like a false positive. So kindly confirm it with an orthogonal method or any other platform. So whenever now the practice is in the laboratory, if you're using COBAS, and if you only get exon 20 insertion positive, it is always better to have another real-time PCR method ready in the lab just to ensure that it is not a false positive. So we have encountered many such cases, and we have like ruled out that it was not exon 20 insertion positive.
And whenever you get real-time PCR1 alteration and not seen in NGS, just don't think it is discordant. Look at the panel which was used in real time. If that panel was covering that particular mutation that you are getting now in NGS, before jumping on to call that case as a discordant. So Dr. Ajay, with ERB2 mutation and amplification, what is your management here?
So again, again like exon 20 insertion, again HER2 is again very heterogeneous, where we can see amplification, expression or mutations. So whatever literature is available, this expression and amplification again is not useful as a therapeutic purpose. only mutations are is targetable. And for again, there is a lot of data available for different drugs like Afatinib, Neratinib, TDM1, Trastuzumab, and Deruxtecan, and few specific targetable drugs like Pozotinib and Pyrotinib. So among these, we are seeing ki Deruxtecan and Pozotinib and Pyrotinib is having a good effect on these mutations or duplications. So this again very specific report showing specific mutations, and it looks like it is a targetable. So if you have the facility of Deruxtecan or other positive, so I'll definitely treat that with the targetable drug. Or otherwise, I'll treat this patient with a chemotherapy, and in second line, may add HER2-directed therapy.
So at least not in first line, you can consider this and reserve for second line or third line. In breast, we are very highly excited about amplification of ERBB2. It's not the case in lung. So if you get amplification or you get a proteins, IC score of 3+, are you excited in lung cancer to start with your treatment?
No, I mean lung cancer, we are not happy to for treating her to 3+.
So mutation is the alteration for ERBB2 when it comes to lung cancer, and in breast we look at amplification. So I think I will stop here. I would like to thank you all, and thank you all the panelists for your valuable inputs. Thank you.
Thank you, everyone. Thank you, Dr. Tabrafenib, and thank you, Dr. Jay Mehta and Dr. Umshri Tata and Dr. Ajay for the valuable talk and giving us insight how to approach and correlating very well with the therapeutic and the clinical aspects. Thank you.
Thank you.
So we are already running behind time. So I'd like to thank all the faculty members, the chairpersons, moderators, and all the delegates for participating. I hope this has been a very useful workshop for all of us. Please join us for high tea and collect all your certificates and mementos, please. Thank you all. Thank you very much.
So we move on to the next session, and
so good morning, everybody, my seniors and my colleagues. So I am Dr. Shikha Dhal, Associate Professor in Shri Ram Cancer Hospital, Mahatma Gandhi, Department of Radiation Oncology. So moving forward, first at the very outset, I would like to thank the organizing team for giving me this opportunity. And now I would like to invite our chairperson, sir, Dr. Shantanu Sharma, sir, who is Professor, Department of Radiation Oncology, to take this session forward in GI malignancies. Yeah. Good morning, sir. So I would like to invite our chairperson for the next session, Dr. Shantanu Sharma, sir. Good morning, sir. He's Professor, Department of Radiation Oncology at SMS Hospital.
Morning,
Over
everyone.
to you, sir.
So our next speaker is Dr. Sudhar Turkar. He is the Director, Radiant Super Specialty in Cancer Hospital, Raipur. Zoom, I think.
Hello. Am I audible? Hello.
Dr. Siddharth, can you hear us?
Yes, I can hear. Am I audible?
Sir,
My voice is clear, Tarun?
Dr. Siddharth, can you hear us, please? Your audio is not there, sir. Audio and slides.
Slides is also not there.
Yeah, we can see your slides now. Your You're not audible.
Hello.
Dr. Siddharth, sir, you're not audible. Can you just unmute yourself?
Hello.
Yeah, now I can hear you. Now we can hear you, sir. Please go ahead. Make it full screen and please go ahead, sir. Yeah, perfect. Please go ahead.
So, I will be presenting the abstract on panitumumab plus M-FOLFOX6 versus bevacizumab plus M-FOLFOX6 as first-line treatment in patients with RAS wild-type metastatic colorectal cancer. These are the results from phase 3 paradigm trial. So this was presented in ASCO 2022 meeting. So coming to the introduction, adding an anti-EGFR or anti-VEGF antibody to chemotherapy improves the overall survival with unresectable metastatic colorectal cancer up to 30 months. And in comparative trials, post-hoc analysis of RAS wild-type patient shows inconclusive result. Overall survival was similar for cetuximab and bevacizumab. And in EU Fire 3 trial, cetuximab improved OS versus bevacizumab. The benefit of an anti-EGFR antibody may be enriched in RAS wild-type patient primary tumor originating in the left side of the colon and rectum. So Paradigm is the first prospective trial to test the superiority of panitumumab versus bevacizumab plus standard chemotherapy for patients with RAS wild-type and left-sided colorectal cancer. So this was a phase 3 randomized open-label study, and patient of ECOG performance status 0 to 1 between 20 to 79 years of age receiving no previous chemotherapy were randomized in 1:1 fashion between panitumumab and bevacizumab. The primary endpoint was overall survival. First, it was being measured in left-sided colon cancer population, followed by it was analyzed in overall population if found significant in left-sided population. The secondary endpoints were progression-free survival, response rate, disease control rate, R0 resection. The exploratory endpoints were early tumor shrinkage, disease control rate in left-sided and overall population. So this is the consort diagram. The patient were randomized between May 2015 to June 2017 between panitumumab and bevacizumab, and patient were further stratified into left-sided population and overall population to make subset analysis. So for statistical consideration, the primary endpoint overall survival was measured in first between left-sided population, and if found to be significant, then only overall survival in overall population will be measured. This was pre-planned. So the targeted number of events were 420 if left-sided population, and 80% power to detect hazard ratio of 0.74 and two-sided significance level of 0.04202. So this is the baseline patient characteristic. So most of the patient were in the age group of 65 to 79 years, around 55 to 56% of the patient in both the groups. Then around 33% of the patient were female. Most of the patients were having ECOG performance status 0, approximately 80% of the patient in both the population. Left-sided, the primary tumor location was in 100% of the patient. It was almost around 80% of the patient. It was left-sided. In panitumumab group, and in the bevacizumab group, it was around 72% of the patient. The number of metastatic site, more than 2 metastatic site was present in around 50% of the patient, and around 50% of the patient were having only one metastatic site. Liver as a metastatic site was there in around 70% of the patient in all the subgroups, and liver as only metastatic site was there in around 30% of the patient. The prior treatment was mostly primary tumor resection, radiotherapy, or adjuvant chemotherapy, only in 5% of the patient. In other, it was around 59 to 60% of the patient. The primary endpoint, overall survival in left-sided population, as you can see, it was 37.9 months, versus 34.3 months. So this was found to be significant as per the predetermined this thing. So it was P was 0.031 and the hazard ratio was 0.82. In overall survival in overall population was also significant with 36.2 months in panitumumab group versus 31.3 in the bevacizumab group. So as you can see at 36 months, around 42% in the bevacizumab and in panitumumab around 50% of the patient were progression free. Then the subgroup analysis of overall survival in left-sided population. As you can see in this forest plot, that most of the subgroups have some benefit for the panitumumab group, although almost everywhere it has touched the unity. In those patients who don't have any primary tumor resection, you can see it is exactly in the midline. It has not favored any group. In those patient, in female patient also, it has not crossed to either of the side. It has almost equivalent in both the groups. So although there was some this study was favoring more towards panitumumab group, but almost everywhere you can see that it is crossing the midline. Now coming to the overall survival population, again those patients who have left-sided tumor has the benefit with the panitumumab group, while those patients who have right-sided tumor, you can see that it is exactly in the midline or more towards a bevacizumab group. In female patient, again there was no benefit in overall population also with the addition of panitumumab. And as you can see, the primary tumor resection in those patients who have primary tumor resection, panitumumab has better as compared to bevacizumab. Now, this is the progression-free survival. As you can see, that the graphs are almost overlapping. Only. So it is almost overlapping. And the response rate, coming to the response rate, so the response rate was panitumumab group was 80.2% in the left-sided population versus 68.6 in the bevacizumab, while in overall population it was 74.9 versus 67.3. The disease control rate was 97.4 versus 96.5. So it was around 95% for all the subgroup, whether in overall population or in the left-sided population. The duration of response was slightly more in those in left-sided with panitumumab group, 13.1 months. In rest, in overall population, it was almost same, 11.9 versus 10.7. And the R0 rate that was being achieved was slightly higher in panitumumab group, 18.3% versus 11.6 months. And in overall population, it was 16.5 versus 10.9. So those patients who achieved R0 resection have more in the panitumumab group. So you can see this waterfall plot. Those patients who have more depth of response, that is more than 30%, you can see 85.8% of the patient in the panitumumab group, while it is only 74.3 in the bevacizumab group in the left-sided population. In overall population, it was 81.9% versus 72.8%. Any adverse event coming, so it was almost same between the two groups, with more grade 3 toxicity slightly higher in the panitumumab group, 71.8% versus 64.9%. The serious adverse event related to the study treatment was 17.8 versus 10.8. And those events leading to discontinuation was 23.8% versus 18.4%, which was almost similar between the group. So this is the toxicities that has happened. So acne-like dermatitis was something peculiar to panitumumab group. The decreased neutrophil count was almost same in both the group, which was the most common toxicity in those in either of the group. And hypomagnesemia is another thing which is known for panitumumab. It was almost exclusively for panitumumab, not there for bevacizumab. Rest all toxicity, I think, was almost comparable between the two groups. Coming to the second line treatment, So second line therapy was almost received by more than 80% of the patient in all the subgroups. The third line and fourth line treatment, 81, 60, more than 60 and 40%. So it is almost same and comparable between all the groups. The fluoropyrimidine as a post-treatment treatment was received by almost 75% of the patient. Irinotecan almost by 60 to 65% of the patient, and oxaliplatin by 20 to 25% in all the groups. So this was also very much comparable between all the groups. The VEGF inhibitor, as you can see, is being used post-treatment around 55% of the patient in almost all the groups. It was either bevacizumab, ramucirumab, or aflibercept. The EGFR inhibitor that was being used post-treatment was higher, obviously, in the bevacizumab group, 54.8%, and it was maybe it was continued post progression in 30% of the patient. For the trifluridine tipiracil was used in around 22 to 25% of the patient in all the groups. So it was the post treatment was almost comparable between the two groups. Now coming to the exploratory analysis of right-sided population, as you can see, as expected. So this curve is almost overlapping, and the median survival is 20.2 versus 23.2, and it was not significant. The hazard ratio is 1.09. So more in numerically more favoring bevacizumab group. So coming to the conclusion, this phase 3 met the primary endpoint, demonstrating the superiority of first-line panitumumab versus bevacizumab in combination with M-FOLFOX6 in left-sided overall metastatic CRC population. Although I can say that it was almost similar. So either of the option is not wrong. In certain population, I will prefer, like in left-sided colon cancer, I will prefer panitumumab rather than in right-sided, because although numerically, but that is better. In those patients in which I expect that there is a possibility of future cytoreductive surgery, then for that to get a R0 resection done, I would consider to use an anti-EGFR drug. So almost all other safety signals and all those were comparable to the previous studies which was being done. Thank you.
Thank you, Dr. Siddharth. I think we can take the question answers after we are done with all the presentations. So our next speaker is Dr. Sandeep Kakkur. He is the head department of medical oncology at Sohna Cancer Center, Chandigarh.
So good afternoon, everyone. The presentation, the topic of my presentation is dynamic trial. Please help me with the slides. So the talk of my presentation is the dynamic trial, which was actually designed with a very high level of sophistication for use of adjuvant chemotherapy in stage 2 colon cancers. We all know that there has been a dilemma in the use of adjuvant chemotherapy for stage 2 colon cancer patients, and majority of the times we rely on clinical pathological variations for selection of adjuvant chemotherapy. Next slide. So optimal management for these kind of patients, it remains debatable, as surgery only cures 80% of the patients, and no clear overall survival benefit has been seen in the adjuvant therapy trials. Even for those patients where we select the patients for adjuvant therapy, different guidelines, ESMO, NCCN, they take different parameters into consideration while selection of patients as a high-risk patients. So the definition is variable. Not all the high-risk features are equal, whether it is the tumors T staging, number of nodes, or the differentiation of tumor. And the survival benefit for stage 2 patients, it remained modest. Why it is important? Because we need a more precise recurrence risk prediction, which will be definitely required to limit the adjuvant treatment to only those patients who are actually high risk and will be potentially benefited from therapy. And by the end of this discussion, we'll be able to know whether we can spare some of the patients who are actually at low risk of recurrence and are unlikely to benefit from adjuvant chemotherapy. So this was a very high level of sophistication, and the trial design was that patients were bound to have the testing of circulating tumor DNA, followed by their categorization into CT positive versus CT negative, and offering them a standard chemotherapy approach, which could actually determine that whether the patient would really benefit from adjuvant chemotherapy or not. So this was the trial design, where after an optimal surgery, stage 2 R0 resections, patients had a plasma collections at week 4 and week 7. And any of the times when ctDNA was positive, patients were offered adjuvant chemotherapy. If they were ctDNA negative, they were kept under observation, versus a standard treatment, which was actually based on conventional clinico-pathological criteria. And the primary endpoint was a recurrence-free survival at the end of 2 years. So this was the collection of ctDNA detection by a safe sequencing system, and classifying the tumor into CT positive versus CT negative. So primary analysis in the ITT population was eligible patients were randomized and they had a blood draw at week 4 and week 7. Primary analysis was done when the last patient reached a minimal follow-up of around 2 years. So around 455 patients were actually randomized over a period of 4 years. 147 at the end of analysis, 147 received the predetermined, pre-specified standard treatment with adjuvant chemotherapy, and 289 were classified for receiving the treatment according to a CT-guided treatment. So it was a 2:1 randomization. So baseline characteristics were almost similar, but it is very, very important to highlight that majority of the patients, they were of T3 stage. 85% of the patients in the CT-guided arm, and versus the standard management, again, 85% of the patients. So at the end of treatment, you can see the adjuvant treatment that received in the standard arm was 28%, and in the CT guided arm was 15%. So you can see here that around 15%, almost half of the patients could be saved from receiving an adjuvant chemotherapy alone, only with the use of a simple blood test, which is testing of a circulating tumor DNA, whether it is positive or negative. So it is very, very important to highlight that half of the patients could be saved from receiving a potentially chemotherapy approach if we do a circulating tumor guided selection of the patients. So a chemotherapy regimen, around 62% of the patients who were positive, they received the oxaliplatin doublet compared to the 10% of the patients with the standard arm. So adjuvant chemotherapy, the only point I want to highlight is in the T4 staging. You can see here that majority of the patients in T4 arm, they received approximately 60% of the patients, they received as per the clinico-pathological criteria. The number was way high compared to the CT DNA based approach. The rest of the arms, I think they were almost similar, which actually favored the CT DNA positive arm. So at the end of 2 years, the recurrence-free survival between the two arms was almost similar, which is actually a non-inferiority study. So if you have a patient where you have a determination of the CT DNA positivity or negativity, could save some of the patients who might not be eligible for adjuvant chemotherapy. So recurrence-free survival was almost similar, but again, I want to highlight that there are certain clinical pathological criteria which are actually important, like T4 staging. You can see here that it actually favors the CT DNA guided arm, where majority of the patients will not have a recurrence even if they do not receive adjuvant chemotherapy. So definitely at the end of this trial, we could clearly delineate that CT positive patients, they had a high risk of recurrence, 86.4% compared to ctDNA negative, which was 94.7. So it could be a potential biomarker which could be available in the coming few years to determine our selection of patients for adjuvant chemotherapy. And you could actually prognosticate it that these are the kind of patients who could actually have a high risk of recurrence if they have a ctDNA positive. But the important flaw that was delineated at the end of trial was that both the characteristics are actually important. You can see here that ctDNA positive patients, the recurrence-free survival RFS was 86.4%, with ctDNA negative and high risk, according to a clinico-pathological criteria, it was 89.7%. And as per the T staging also, you can see ctDNA negative, it is 81% versus ctDNA negative with T4 staging, it is 86.4. So that determines that majority of the patients in the trial, they were T3 negative and they were bound to have you can say recurrence-free survival even with the end of without the receiving the adjuvant chemotherapy. So I think as at the concluding remark, I would say that we need a fair number of T4 patients in the trial as well to actually delineate that there could be some other factors which are actually important apart from only ctDNA positivity. So the summary of the slide is, for patients with stage 2 colon cancer, ctDNA guided approach with positive compared to standard of care, again, it number one, substantially reduced the proportion of patients who could receive the adjuvant chemotherapy. So 50% of the patients could be saved, and it did not compromise the RFS. Patients who have ctDNA positive, they might derive the RFS benefit from adjuvant chemotherapy. ctDNA negative, so they are actually at a low risk of recurrence and they might not be the suitable candidates for an adjuvant chemo, but that all should be taken with a word of caution that still there are some clinico-pathological criteria which are actually very, very important apart from ctDNA positivity in selection of adjuvant chemotherapy. Thank you.
Thank you, Dr. Sandeep. Our next speaker will be Dr. Sunil Chopade. He's the Assistant Professor, Consultant Medical Oncology at TMH, Mumbai.
Good afternoon, everyone. So I will be presenting a phase 2 study, single agent PD-1 blockade as a curative intent therapy in a patient with mismatch repair deficient rectal cancer. This was presented at this ASCO meetings, and this study made to the news channels and the social media. So moving to the background, therapy for locally advanced rectal cancer has included chemotherapy, radiation, and surgery. Neoadjuvant chemotherapy and radiation therapy followed by surgery is usually the standard treatment protocol for rectal cancer. While cure is frequently achieved, radiation and surgery have a life-altering consequences. Following chemotherapy and radiation, a portion of candidates become for non-operative management. Mismatch repair deficient rectal cancer, it constitutes about 5 to 10% of the all rectal cancers. It is relatively resistant to chemotherapy. Checkpoint blockade is highly effective in metastatic mismatch repair deficient cancers with a complete response rate of 10%. So the hypothesis was, in a mismatch deficient rectal cancer, PD-1 blockade may be able to either replace chemotherapy or replace chemo and radiation therapy or replace chemo and radiation and surgery. It was a phase 2 study. Dostarlimab, it's a PD-1 immunotherapy. 500 milligram IV every 3 weeks was given for 6 months. Radiologic and endoscopic evaluation was done. If residual disease was there, chemo-RT was planned. Still residual disease persisted, surgery was planned. After chemo-RT, if there is a complete clinical response, then patients were followed up for 4 months. If there is a complete clinical response after dostarlimab, patients were followed up for non-operative management. Patient population was stage 2 and stage 3 mismatch repair deficient rectal cancer. Target enrollment was 30 subjects. Study objectives, the primary objective was overall response rate of PD-1 blockade with or without chemoradiation, pathological complete response or clinical complete response rate at 12 months after PD-1 blockade with or without chemoradiation. Secondary objectives were safety and tolerability. Response criteria, the overall response was decided by rectal MRI and endoscopic examination and were graded as stable disease, partial response, near complete response, and complete response. Clinical complete response was said when endoscopic examination, there was a visual disappearance of the rectal primary and normal digital rectal examination. On rectal MRI, there was a lack of signal at diffusion weighted imaging with a scar on T2 weighting images. Each target lymph node must have decreased to short axis to less than 0.5 centimeter. The null hypothesis was an overall response rate less than 25%, which is based on the response to chemotherapy in MMR deficient colon cancer of 7%. Rejection of the null hypothesis required a response in 11 or more patients. Baseline characteristics, the study had 18 patients, 12 were female and 6 were male. The median age range was 54. It has a stage 2 and stage 3 cancer. Node positive constituted about 94% of the patient. This was an individual response to PD-1 blockade in first patient at a follow-up of 23 months on digital rectal examination, endoscopic based response and rectal based response on MRI was complete response. So patient was in complete clinical response. These are the images. Patient follow up at 3 months, 6 months, at 12 months and 18 months. So patient was in complete clinical response post 6 months. So there were 14 patients at the median follow-up of 6 months. All patients had a complete clinical response. So it was a 100% overall response rate. If we see at the follow-up of 6.8 months, 14 patients had complete clinical response. 100% clinical complete response in first 14 consecutive patients. No grade 3 or no adverse events were observed. No patients have required chemotherapy, radiation, or surgery. No disease recurrence observed during the follow-up period, and longer follow-up is required. To conclude, this data provide the framework for immune ablative therapies, highlight the clinical impact of biomarker-driven therapy in early-stage disease. The tumor agnostic mismatch repair deficiency population of early-stage disease has the potential to eliminate the need for chemotherapy, radiation, and surgery in up to 3 to 4% of patients. And this has the potential to be translated rapidly into the areas around the world without access to modern chemotherapy, radiation, and surgery. This was published in NEJM. Thank you.
Thank you, sir. So our next speaker is Dr. Kaushal Kalra. He is a consultant medical oncologist at BMMC and Safdarjung Hospital, New Delhi.
Yeah, good morning all. Yeah, good morning to all. Am I audible? Hello?
Yes, you're audible. Please carry on.
Yeah. So today I'm presenting improved study randomized intermittent versus continuous panitumumab in combination with FOLFIRI for the first line metastatic colorectal cancer, which are RAS and BRAF wild type, which are presented in ESCO 22. So first we'll go to the background and rationale. Intermittent versus continuous FOLFIRI regime. It was given and it was seen that both are equally effective. So intermittent is equally effective than the continuous FOLFIRI regime in metastatic CRC. Combination of FOLFIRI with panitumumab is the standard first line option in the RAS and BRAF wild type CRC, metastatic CRC. The toxicity and resistance, these are the two important drawbacks of the continuous exposure to the EGFR blockers. In FIRE3 trial, when FOLFIRI was given in combination with the cetuximab anti-EGFR, it was seen that maximum tumor response was seen approximately 4 months. Median time to maximum response was approximately 4 months in RAS and BRAF wild type. It suggests that if we will continue the therapy, there will not be any additional benefit, but definitely toxicity will increase. So this was the strategy behind this, rationale behind this study. And another thing, as we know, if we will continue the EGFR blocker, the resistance will increase gradually, and while declining, while the withdrawal of this EGFR therapy, the resistance will decline. On the similar concept, it has been seen that in later line we re-challenge with the anti-EGFR therapy, we will get some response. But there is data is there, but there is very sparsity of data. There is lack of data. Can we use the intermittent strategy? Because the biological rationale behind these both strategies are the same. So as per this background, this study was planned, improved study. It is randomized, non-comparative, open label and multi-center phase 2 study. This combination of FOLFIRI with panitumumab was used in the first line unresectable RAS BRAF wild type metastatic CRC. Randomization was done 1:1 in arm A. Continuous therapy FOLFIRI plus panitumumab was given till progression, while in another arm only 8 cycles were given. After that, treatment-free interval was given. And tumor assessment was always done every 8 months in both the arms. The primary endpoint in this study is progression-free survival on treatment. On treatment, progression survival. But if patient progress on the treatment-free interval, those were excluded. So on treatment, progression-free survival was considered as the primary endpoint in this study, and sample size was calculated as per the statistical test, binomial test, on the basis of non-inferiority hypothesis, and sample size of 68 patients in each arm was taken, and more than 25 patients alive and without progressive disease at 1 year to reject null hypothesis. There was no formal comparison between the two arms. This is phase 2 study. Secondary endpoints: safety profile, overall response rate, deepness of response, overall survival, quality of life, and translational studies on tissue and blood sample. That is ctDNA. Eligibility criteria: histologically proven adenocarcinoma, wild type RAS and BRAF in metastatic CRC, at least one miserable metastatic lesion as per RESIST 1.1, more than 18 years of age, ECOG PS up to 2, and adjuvant therapy is allowed only if there is minimum interval of 6 months between the relapse and end of the adjuvant therapy, adequate bone marrow, liver, renal, and cardiac function. In concern diagram, total randomized patients were 137, in arm A 69 and arm B 68. And in arm A, on treatment till now it's 7 patients, while in arm B it was 25 patients. Arm B is intermittent group. Baseline characteristic: there was no formal comparison in the between the two arms. There were certain differences, like in arm A, 22% patient receive adjuvant therapy, while in arm B it is more than 30% patient. Liver limited disease was in 20% in arm A, while it is only 12% in arm B, and more than one site of metastasis was in 67% in arm A, while it is 74% in arm B. And primary tumor location left-sided, in both arms there is a maximum number of patients. More than 80% of patients are in left-sided in both arms. So we can see the median number of cycles are equal in the both arms, 13. But you can see only 10% patient in the arm A are still on ongoing treatment, while 90% discontinued. In arm B, it was 37 patient, 25% patient, 37 patient are still on ongoing treatment, and 63% discontinued. And this is a point to be noted that in arm A, 17% patient discontinued due to adverse event, while in arm B, only 4% patient discontinued. In best responses, in arm A, there was better responses. Complete response was 7% versus 3%. Partial response 59 versus 54%. Stable disease was 37 versus 32. And R0 resection rate was 19% versus 15%. And disease control rate 94 versus 90%. So come to our primary endpoint. You can see PFS on treatment is better in the intermittent arm. It is 17.1 month versus only 13.2 month. 4-month difference is there in the intermittent arm, and 34 patients is still alive and without progressive disease at 1 year. Come to the according to the sidedness, we know EGFR blocker are more effective in the left-sided. Similarly here, around 7-month difference in the both arm. In intermittent arm, 20 month is median PFS from treatment, while it is 13 months in continuous arm. Come to the safety analysis, we can see skin-related toxicity and hypomagnesemia is significantly more in the arm A, continuous arm, as compared to the arm B. So on conclusion, primary endpoint has been met with the 34% alive and without progressive disease at 1 year in the intermittent arm. So it is intermittent strategy seem to be particularly promising in the left-sided RAS BRAF wild type unresectable metastatic CRC. Median PFS is approximately 20.2 months. And it yield a lower skin toxicity and lower the treatment discontinuation rate. OS data is still not mature, and ongoing analysis may provide the better insight on refining the intermittent strategy. And this study that take on a relevant value in the COVID-19 pandemic era suggests that the intermittent FOLFIRI panitumumab combination may be an effective strategy for the RAS BRAF wild type metastatic CRC that deserve further investigation in phase 3 trial. Thank you.
Thank you, Dr. Kaushal. So now with the 4 abstracts of ASCO, now we come to some real case scenario. So I invite for the panel discussion. Moderator is Dr. Rahul Sood. He is the consultant medical oncologist at Command Hospital, Bengaluru. And our esteemed panelist, Dr. Devesh Goyal, senior consultant medical oncologist at Fortis Hospital, Jaipur. Dr. Samiksha Dubey, consultant medical oncologist at Nelson Hospital, Nagpur. Dr. Ajay Singh, consultant medical oncologist, TMH, Mumbai. Dr. Kanika Sharma, associate consultant medical oncology, Max Super Specialty Hospital, Mohali. Dr. Lalchand, assistant professor at SMS. Dr. Mukesh Bansal, consultant medical oncology at IVY Hospital, Mohali. Can we have some more chairs? And Dr. Himant Dadij, senior consultant medical oncologist from Kota.
Right. Good morning, one and all. Thank you to the organizers, and nice to see a very full house and all present today morning on Sunday, even on Sunday. So my job today is to discuss regarding the 4 abstracts which were just presented, and I think this year is special for colorectal cancer. And starting from what way we were last year, a lot has happened, so it's going to be exciting. So I've tried to tweak the panel discussion. I've not made it a case-based panel discussion, but I would like to know from opinions from all of you who are sitting here and how we go forward in 2022. So these are the 4 trials, and I'll start dissecting them out one by one. And so I'll start with the Paradigm trial, and that was the first trial that was presented. I mean, this was the last trial that was, first trial that was presented. That is the panitumumab versus the bevacizumab. And this was done in all wild type, as well as especially also in the left-sided, where the chemotherapy was combined with either panitumumab or the bevacizumab, with overall survival being the primary endpoint. And we are very fond of overall survival wherever we go. So a very, very pertinent study until progressive disease or till toxicity or withdrawal of consent. The secondary endpoint was the following. So when we saw the primary endpoint, the overall survival in the left-sided population, well, it was almost a no-brainer. There was a significant improvement. And when we come to the primary endpoint in the overall population also, there was surprisingly a benefit. So my question, and I'll start in the order in which you are sitting. So I'll start with Dr. Samiksha. So what is the incidence or prevalence of RAS mutation in your clinical practice, left-sided, right-sided? Is there a change that we've seen now?
Left-sided, we are getting around 10 to 15% patients who are wild type.
Right.
And in right-sided, the same number goes for the mutated patients as of now.
Okay. So you mean to say that the mutations are more on the right side? Or are you seeing more mutated?
I'm seeing more mutations on the right side.
Right side, right. Dr. Kanika, what about your experience?
So same, but not 10 to 15%. We have a more wild type on the left side. So,
right.
we are actually using cetuximab for that. And on right side, yeah, definitely around 20% of the patients will be having RAS mutation.
So where to place the transverse colon here? Is it the left side or the right side? And the age-old criteria, where do we place it right now? Is it still the sigmoid flexure that we use, the cutoff for that? Yeah, so I think we agree that the mutations are more on the right side, and in our clinical practice, we almost see mutations as much as almost 40% in whole of colorectal, and that's more in the right side that is there. So your question, and I think you're Dr. Devesh, right? So Dr. Devesh, do you perform a mutational analysis in all your cases of metastatic CRC upfront?
Yes, upfront I am doing all these tests.
So what are you doing upfront? Are you just doing the RAS and stopping, or in 2022 are you adding something more to
RAS, BRAF, as well as HER2 and MSI and PDL1.
Yeah, so I think that is what we are doing in majority, because we should know our plan of
Whole
action.
labs are giving on comprehensive panels.
Yes,
of colorectal, so all tests are available in single comprehensive panel.
So do you wait for that thing to come? Because I think the turnaround time is as much as almost 4 weeks for
I
this.
think I will start chemotherapy.
Right.
Initially FOLFOX or FOLFIRI, then I will decide, and I will add the further line of targeted therapy in second cycle.
Right. Dr. Ajay, what do you do?
Same here also. We also do. We are right now doing individual test.
Right.
And we are starting chemotherapy, and based on the reports we are adding. But now we are tending towards doing the whole genome sequencing or NGS and deciding the treatment based on that.
Is tissue an issue also in colorectal cancer? Do we just do the KRAS, NRAS, BRAF, start the treatment, and maybe subject the rest of the tissue, or you wait again, like Dr. Devesh said?
In this colon, no issue of tissue.
Yes, that's one. Unlike lung, I think colon there is ample tissue, and you can subject the patient once again. So I think so next generation sequencing versus hotspot, Dr. Laljan, Dr. Mukesh, sorry. Yeah.
Sir, mostly hotspot mutation testing. NGS is not much available and affordable in our setting. So
Right.
most of the patients we are performing hotspot only, but whenever we can do, we are tending towards NGS now in some patients.
Anywhere you've done liquid biopsy for your patients first line, or do you reserve it for the second line?
No, so not available. And
Right. Dr. Laljan, last question. What is your chemotherapy backbone of choice with RAS wild type with liver mets?
Yeah, if upfront patient is there, then FOLFOX.
Right.
And depending on the what we have used earlier, if patient is metastatic now, so FOLFOX we will use if patient is upfront.
Right. So there was some data saying that if their patient has multiple liver mets, the oxaliplatin is slightly detrimental to the thing. Are we still following it, or we go ahead with the old FOLFOX, which is there?
Yeah, still.
Yeah, right. Dr. Samiksha, your take on the last question, then we'll move forward.
Usually we start with oxaliplatin based only, but if there is slight derangement, let's say just the liver enzymes which are deranged, not the bilirubin, then we tend to go towards irinotecan based.
Yes, so I think there's nothing much to choose between the two, and still in 2022, that is what we do. So since the mic is with you, I'll continue with you. So what is the preferred biological agents of patients with RAS wild type metastatic CRC, right and left sided? What do you do?
Left-sided, of course, EGFR therapy, so cetuximab or panitumumab. And right-sided, if they're wild type, we are beginning with cetuximab.
Okay, so now that is where I wanted and everybody is smiling. So the mic will definitely, I'll take everybody's opinion on that. Thank you, you've done my job. Right, please. Yes, so Kanika, you, Dr. Kanika.
In the right-sided, we are using bevacizumab, and even if the patient is not affordable, we are not doing the testing because anyway we have to use bevacizumab. So in right-sided, we are.
So Kanika, if the patient is wild type and you've done the hotspot NGS, I've done the liquid biopsy also, and it's still wild type, it's an ascending colon, not going into the transverse colon, will you still be tempted to give an anti-EGFR? Okay, right. Yes. So
still I am concurred with Dr. Kanika. Still I'm not using this cetuximab in first line if it's still wild type, but can use in second line. But data and previous data and biologics and theories are not supporting the use of this EGFR in first line in this right side column.
So do we need to even test for RAS mutation in the right side? As Dr. Kanika said, no, we go ahead with bevacizumab.
I think this will not require, but we are doing RAS, BRAF as well as MSI for further lines of therapy.
Right.
If the patient are fail on this bevacizumab, then we can take chance on this cetuximab if there is wild type. Suppose mutated, then we are not using, but if there is wild type, then can use in second line of cetuximab, some
advantages there. So I think we had these two trials which were there, and both were cetuximab based. We had the GB trial and the FIRE study, and both these compared cetuximab with bevacizumab. And in majority of the things, cetuximab was found to be inferior to bevacizumab. But then in came this trial known as the paradigm trial, and with this paradigm trial, and you've seen the data which is there, and I'll just reflect on the data which is there and try to convince Dr. Kanika on the right side. So what do you say about the data? Do you see clinically significant difference with panitumumab compared with the bevacizumab in patients with RAS wild type, that is all wild type, and left-sided metastatic CRC in the clinical practice? So what are your thoughts? Anybody can take it. Dr. Ajay.
For RAS wild type, I'm definitely tended towards panitumumab or cetuximab.
Because majority of our data was based on the cetuximab 2 trials, but these are some trials which has shown. See, the thing is, many times what we are getting are liver-limited disease, which are probably not upfront resectable, but liver-limited disease where we can do, if we can call that as a term known as conversion surgeries. So any experience on that? Since the mic is with you.
Yes, sir, definitely. If there is a oligometastatic like single meds or few 1 to 3 meds, and after 6 months of therapy, we are seeing a good response. Then definitely we are again having a multidisciplinary discussion, and most of the patients are getting operated also.
So as you can see, even in the overall wild type, the panitumumab with FOLFOX did better. In fact, you see the number of events were less, patients having a better median overall survival, which is there. And somehow I find the panitumumab is much easier to give than cetuximab because of the dosage schedule which is there. And if you see, the data showed that the overall population, considering the right-sided primary tumor, 21%, and another 25% had the bevacizumab, which was. So even in the overall data, where the panitumumab was given to the right side, there were 21% of the disease. So, so something to ponder upon on things. And that is what I mentioned about the conversion surgery or the R0 resection rates. So Dr. Mukesh, same question to you. Any experience? Because I want to know from everybody, because we shouldn't write off metastatic CRC now, especially in a liver-limited disease.
Sir, if there are chances of converting to resectability, then I think now we can, even with the paradigm trial showing, we can go for the panitumumab even in the right-sided metastatic CRC. But otherwise, we are just using bevacizumab only, even if it is RAS wild type.
Right.
But if there are chances oligometastatic disease, we can give kind of neoadjuvant kind of treatment. Then now we are tending to use active panitumumab.
See, with bevacizumab, one always a problem is the surgeon says is stop a dose before, and they're not very happy, and many of them will ask for a 6-week gap or something like that. So this is a problem which is always there. So the wild type conversion surgery, I think the anti-EGFR also does work. Dr. Lalchand, your experience? Sorry,
Yeah,
Dr. Hemant. Sorry.
I think so. I'm completely agree with Mukesh. I think we can start if in liver only few metastases are there, and we can think that we can convert it for
Right.
surgery.
Right. Okay, so now that, yeah, please, you want to say something?
You can use the upfrontly this panitumumab. I think more and more number of trials and data in further in future years, so that
Yes.
supporting the use of this panitumumab in right side colon also.
Right.
So can we can use, and I think in borderline resectabilities, borderline resectable, if their surgeon wants to take chance, they are more resectable compared to apparently resectable, so can use the panitumumab.
I remember 2019, this is before the 2 COVID waves. I happened to listen to a great person on colorectal cancer, and he said it is 80-20, 80% bevacizumab, 20% anti-EGFR. Then he said that on the left-sided, you can go either way. That is, you can either go for bevacizumab or anti-EGFR, but right side is a no-brainer. You have to go for bevacizumab. But I think that is changing as we go forward.
For this trial, many trials said that in right side cetuximab or EGFR may be detrimental. So
Yeah. There was this coin study. I think there was a cricket study, coin study, which said. So things are changing. Okay, so we go to the next study, and I think this is what woke up the medical fraternity, especially the neurosurgeons, the cardiac surgeons, and made us more respectful in their eyes. This is the study of the Dostarlimab, which was there, and it was very nicely presented from our colleague over here. So this is what he did, and probably he woke up everybody who was sleeping on a particular day. And what he showed was a complete response, which was there, the clinical complete response, which was there. And there was no disease either on the PET or the MRI or anywhere else. And this has opened a channel for all of us. Again, nothing on endoscopy in all these patients, the rectal MRI, the PET, nothing was there. So MSI now, so I'll start with whoever has the mic. Yeah, so MSI in your experience, Dr. Kanika.
We are doing MSI testing in metastatic disease, but the positivity rate is around 5 to 10% only.
What about the early stages, the stage 2 or the stage 3? Are you doing your MSIs?
Yes, because
Right.
of the adjuvant setting, whether it's MSI stable, and that we are deciding for the adjuvant capecitabine. So we are
Right.
doing. And in that also, it's actually less than 5. Most of them are coming as MSI stable only.
Right. What about your experience, MSI? Stage 2, stage 3, stage 4? Stage 1 is the only thing left, and I don't think we have ever seen stage 1 unless somebody has.
Stage
So
4, I have seen only less than 5% cases. And
Right.
stage 2 or 3, I think I am doing in 50% of patients.
Right.
Still less than 5%.
So now with this study in 100%. So anyway, stage 4 you all mentioned we need to do. So stage 2 and 3 is
Yeah,
something.
after the introduction of this study can do in all patients, the MSI can offer to all patients in locally advanced stage 2 or stage 3.
Right.
Upfrontly.
And what platform for MSI? Like they use Ventana over there, which is not of, but like the speakers before us also said, and from Tata, because this is the easy platform which is available. So do we use the same platform? And
Labs are doing the different platforms. I have
Yes.
not heard about this Ventana platform.
Right. So Dr. Ajay, your experience, immunotherapy in rectal cancer, stage 4 first, and then what is the future?
Only sir, for immunotherapy, MSI is I think among all the markers available, PD-L1, TPS, CPS, I think MSI is the best marker we are available. And whenever there is we are not having a very high percentage of positivity, but whenever there is a positive and patient can afford, definitely we are offering that upfront.
What about tumor mutation burden in colorectal cancer? Are we doing it? Is it a thing of the?
It is not, sir. Regularly we are doing.
Right.
And MSI, I think, is a preferable marker.
Right. So are they all related? The tumor mutation burden, the MSI, the PD-L1 score, the so-called CPS score. Are we still learning, Dr. Mukesh?
I think, sir, we are still learning.
We are still learning. That's the safest answer. And that is why I put it forward, because I also don't know the answer. But I think any one of them or any two of them is positive. I think these patients should be given immunotherapy.
Yes.
So since you have the mic, so based on the study, what is your opinion of using PD-L1 blockade in locally advanced mismatch deficient colorectal cancer? Today is Sunday, tomorrow is Monday. So would you be, like they ask, Monday morning practice, and obviously the drug is not there, but you have the cousins which are available. So would you be tempted?
Personally, I have no experience in neoadjuvant kind of setting.
Right.
Which the trial was designed, and I think the study is promising, but it is a very small phase 2 study, so we can't say it's a practice changing study.
Right. I'll stop you there because those are my next questions. So I'll bring it back to you. Right. So I'm like, we are all visionaries. So I just put on these three things. With all these, do we see things coming in pancreatic, gastric, prostate cancer? Is it a revolutionary study? I have not used the landmark study. I've used a revolutionary study, and eligible patients no longer have to accept functional compromise with the FOLFOX or FOLFIRI in such patients. So is it?
Yes, sir. It's a revolutionary study because even if I don't remember any small study also which has showed 100% response.
Absolutely.
So in that way, it's a different, it's a revolutionary, but still early days to come.
Early days. So yes, the pros for the study is 100% CR and only IO. So the surgeons, I hope there are no surgeons. Radiation doc, sir is there. So chemoradiation was planned in patients. So yes, there maybe it's something which is a start. But like you mentioned, small size endpoint is overall response rate, a short follow-up. And though the correlation was there with PET MRI, but we need more data, which is definitely there. But yes, something to wake us all up and to use immunotherapy probably in the way to go forward. What about hyperprogression? The problem is always hyperprogression that we call or pseudo progression, and we keep quarreling on whether it is progression or not. So Dr. Hemant, this may be also a problem.
Yeah, it may be a problem, but in this study, I think they haven't shown anything.
They have not shown anything. So this is probably another thing that we need to see about hyperprogression. I think they didn't mention too much about hyperprogression in that. Right. So yes.
This locally advanced, if this study is approved in future years, so the further colostomy can be avoided.
It's already a part of the NCCN right now. If you see, and if you update your NCCN, it is a CAT indication which is there. The drug is already there, so this is approved. So it's just a matter of time. So we come now to the second last study, that is the IMPROVE study regarding the continuous and the intermittent FOLFIRI in the standard first line. So my question to you is, Dr. Samiksha, I'll start with you. So do you face this problem of what you call resistance, which is there? How much time do you have? Okay, fine, right.
Could you repeat the
Sorry, my question is the second one to you is emergence of resistance. Do you have patients that where you've given 6 cycles, they've had a very good response, then you plan for another 6, and within the next, obviously we do the PET scan only after another 6. So do we have individuals who develop toxicity or resistance during that period of time?
Yes, during that period of time, the toxicity profile does emerge in those
Right.
patients, and about 25 to 30% of the patients by like 10th dose or so start to drop out because of toxicity. And the resistance pattern usually is seen not in very high number of patients, but that also starts emerging towards the end of your next 6 doses that you've planned.
So how many people have you given the whole 100% dosage of FOLFIRI? You know, the 5-FU causes diarrhea, the irinotecan causes diarrhea, the mechanism is totally different how they cause diarrhea. So
Complete number of cycles, I probably would say around 70% of patients.
yes. So that's a major problem, I think. And if you add another, obviously not this case, but these two can cause problems. What about you, Dr. Kanika?
Same, actually, they are not very easy drugs to give, and the skin toxicity is very hard and actually very cumbersome. So
Right.
yeah, patient, they are very reluctant to take these drugs when the toxicity start appearing. And definitely diarrhea. It's very difficult to counsel whether it's because of the 5-FU or panitumumab, but since they are paying so much for the panitumumab, so they want to stop that drug because of the side
Correct.
effects.
So how long do you do it? How long do you give the 12 cycles?
So yeah, that is our goal, to give 12 cycles, but yeah, in
Majority of the patients, I think, just scrape through 12 cycles somehow or the other. Either you decrease the dose or increase the duration. So do you think that the intermittent strategy should work? Would you definitely propose after this study of an intermittent dosing?
This trial only in the subgroup, they have shown that people who have used panitumumab after some gap, so the
Yes.
response was better.
Yes, so that is what the study showed, was that yes, there was a benefit. You give them 8 cycles and treatment-free interval. I think we had an Optimox study or something where the oxaliplatin was also stopped or something like that. But here the entire regime was stopped for 8 cycles. Look for progression and then re-challenge, which was done. And if you see the curves which are there, you look at the response or the PFS which was seen, it was better because the events were less. And look at the median PFS which was there that is 17.1 months. But there was a caveat definitely on the sidedness of the study. The left side, no brainer. And we've seen even in re-challenging with anti-EGFR also, there was definitely a good response in that. So what about right-sided lesions, Dr. Devesh, intermittent or continuous?
I think we are discussing on this intermittent versus continuous.
Yes.
We all medical oncologists are afraid. You want to off. I think just after completing 12 cycle, we put on the capecitabine maintenance or panitumumab maintenance. So I think I am afraid why I will stop this treatment. We will give some treatment, capecitabine maintenance or panitumumab maintenance. So I think more and more number of data in future years of intermittent is required to implement in our practice.
So no intermittent as of now, even on left side.
I think we all are. I think we are.
What about the toxicity? What about that subset of patients who are developing that?
So I think
grade 3
in my
toxicity?
practice, I have seen only 10% toxicities. Patients, majority have completed in 90%.
Right.
I am slightly afraid with diarrhea, is still grade 1 or grade 2, and with panitumumab, skin toxicity is more compared to the cetuximab. And I am feeling the hypersensitivity reaction is more with cetuximab compared to the panitumumab. So the data are equal for both. So afraid for skin toxicity with this panitumumab mode. But I am afraid why I will the treatment free interval. So we put on the patient on capecitabine maintenance or panitumumab maintenance. कुछ तो चलना चाहिए ऐसा.
नहीं कुछ तो चलना हमारी तरफ से पेशेंट भी हाथ जोड़ के बोलता है कि कुछ देर तो ब्रेक दे दो सर हमें अब हो गया कब तक चलेगा. So that is another thing which is there. So yes, there was no maintenance. Correct. Right.
So still we are giving some drugs for all or capecitabine maintenance or something.
Right. Dr. Ajay. So intermittent in between?
We are also in favor of continuous only because
right.
They are afraid to stop and patients are also having a lot of concern
right.
while stopping the therapy.
So we are continuing the 5FU or the capecitabine part.
Right.
Anti-EGF are slightly difficult to continue because of toxicity and financial issues. So we are mostly stopping that.
Correct. Right. What do you?
I think continuous is right now is a treatment of choice, but in future maybe intermittent.
I think we'll need to individualize patients. I think toxicities plus patient preference, because patient preference in 2022 is also very important. And in case we need to stop or intermittently give, probably we can quote this study.
Maybe
yes.
Financial toxicity will be more.
Financial toxicity is another thing which is there. See, what happens in, I think, left-sided colon is the expression of EGFR continues. So I think studies have shown of re-challenging individuals. But yes, right side is a different subset altogether, which we know. And the rationale is, I think, we all know because of the aggressiveness of the disease, which is there. Lesser toxicity. Will you preserve the regime for PS1 plus patients with pre-existing comorbidities or whole patient population? I think you will all answered. So work in progress, and we need to wait. So what the author concluded is, what do we do in the COVID-19? If you open the up to date, the first thing they say after the first paragraph is what you do in COVID-19. So suppose, God forbid, it should not come. If the third wave just comes, is it a way to go forward in our patients? Yes. So that's that. I think yes, correct. I think 5 minutes, or how many minutes? 4 minutes. Right. That's all I need. Right. So I'll be very dynamic in the next 4 minutes. So this is the dynamic study, and I'll start. So what is the opinion of role of adjuvant chemotherapy in stage 2 colon cancer? I think half of us have already decided. So what do we do? MSI? Right. So doublet and triple. How do you decide? MSI is the way to go forward. Okay. So tell me some risk factors, and we go back to the DM days. Yeah.
Both
right.
Whether there was a tumor perforation, elevated CEA levels, LBI was positive or not. So all these factors were taken.
Right. So these are markers which we all had, and we've all seen that despite using all these markers, there were individuals where we did not give chemotherapy, and maybe 3 to 4 months down the line, the patient became metastasized. So this is what we have now, and that is the circulating tumor DNA, where this has come as a marker. And I know it is again work in progress, but this is another marker which is there, if I can say. And so what they say is that the emerging research indicates that circulating tumor DNA can reveal the presence of residual cancer after surgery with much higher precision than the presently available tools, like you mentioned, and can help with the treatment precision regarding a need of chemotherapy after the surgery. So this is what the author quoted. And the problem with circulating tumor DNA is this, that is the sensitivity rate, the turnaround time, and the thing. So Dr. Mukesh, circulating tumor DNA, any experience?
No, sir. No.
I think the only thing we read was that it needs to be validated. So
It needs to be standardized.
yes. So
testing before
any
we can
experience of any panelist of circulating tumor DNA? So we are all equally blind on this. So very nice. So so yes, something, because now this is going to be the in thing, circulating tumor DNA, which is being there. And people say that it is practice changing, but we need validation, which is there. But what this study showed that the recurrence-free survival with individuals who were not given chemotherapy and did not have circulating DNA was as good as the ones who were. So that means it is a tool which can be used. So how do you perceive this study? And I'm asking you because I myself don't know. So yes.
Can avoid the unnecessary chemotherapy in these subsets of patients who are ctDNA negatives after the surgery.
Right.
So I think this pool may be 30 to 40%. They can avoid the chemotherapy and chemotherapy related toxicity also.
So would you use as a single modality, or will you use it with all the other criteria which are there? Suppose the patient is MSI low, doesn't have any risk factor, and the ctDNA is also there. Or is it a single entity which you'll be using?
I think will correlate with other findings also, MSI, obstruction or perforation, high risk features in pathology.
Right. So I think, yeah, please.
This can, if after validation, it can be equivalent to like in breast. So it will just give confidence to the doctor to stop. Otherwise, out of fear, we are just over treating the patient.
Absolutely. The overfear of continuing 12 cycles and then panitumumab and then 5FU. So that is what is there. And yes, the financial toxicity also comes along with it. Right. So maybe we can bring down those number of patients, and maybe the other patients may not have the other risk factors and may have a high ctDNA. So that is the other way of looking at it. And I think I already mentioned this. And the other question is, can clearance of ctDNA be used as an endpoint in adjuvant trials evaluating novel therapies and treatment escalation and de-escalation? And this is again a futuristic question which is there. What they want us to do is to repeat ctDNA maybe after 3 cycles, 4 cycles, and so forth. So maybe in the future again. And this is the conclusion. The future of adjuvant therapy decision making in stage 2 colon cancer is exciting, like it is in colorectal cancer. So thank you one and all, and thank you all. Thank you.
Our next speaker is
Good afternoon, everyone. I thank the organizers for inviting me to present this study. Can we have full screen? I think this is a different presentation. The prior one already, which you had shown earlier, that's my presentation. That nimituzumab, yeah, that one. Yeah, good afternoon, everyone. Yes, shall I start? Thank you. This study looked at the efficacy of adding nimituzumab to single agent gemcitabine in advanced pancreatic cancer, which are having KRAS wild type. This is a prospective, randomized, double-blind, multi-center phase 3 study conducted in China. A brief background about this study. We all know that pancreatic cancer is one of the most lethal cancer, and majority of patients present in a advanced stage. And in the previous symposium, also we've seen that rapidly targeted therapies, molecular profiling, immunotherapy, they are flooding in the management of colorectal cancers, lung cancers, breast cancers. But where are we in pancreatic cancer? Still, chemotherapy is the main treatment modality for majority of patients in advanced pancreatic cancer. Either it may be single agent or a combination of chemotherapy drugs. With that, what do we achieve? We achieve somewhere around 8 to 11 months of median overall survival. I think my slides should not move. Slides should not move. Yes. So we are coming across a lot of molecular markers to choose patients and also predict prognosis. So KRAS is one such molecular marker. We all know that wherever, be it a pancreatic cancer, lung cancer, colorectal cancer, whenever KRAS is mutated, we know that it is a poor prognostic marker. Compared to other cancers, KRAS mutation is very, very common in colorectal cancer. If you look at the data, roughly around 80 to 90% of pancreatic cancers harbor KRAS mutations. Only 10 to 30% may be KRAS wild type. So today's this study's interest is on nimituzumab. The nimituzumab is an anti-EGFR monoclonal antibody, which blocks EGFR signal pathway, as well as it may induce immune-mediated cytotoxicity. Prior to this, in the Annals of Oncology in 2017, there was a publication by German researchers. They looked at addition of nimituzumab to gemcitabine across all pancreatic cancers in advanced stage. However, it did not show any superiority, but in the subset analysis, only small percent of patients had a KRAS wild type. In that, they showed that there is a doubling of OS, which was unheard of in pancreatic cancer, doubling of OS. They had showed that from 5.67 months to 11.62 months. But the proportion of patients who had a KRAS wild type in the study was very, very small. So this led Dr. Kin and Dr. Lee to propose this notable study to look at the efficacy of nimituzumab in KRAS wild type pancreatic cancer. So they designed this study that they included patients who are having a advanced pancreatic cancers, who are having KRAS wild type and aged more than 18 years with KPS of 60 or more. They were randomized, the study population was randomized in 1:1 fashion, either to nimituzumab plus gemcitabine or gemcitabine alone. Nimituzumab was given 400 mg fixed dose weekly and gemcitabine 1000 mg per meter square, day 1, day 8, day 15 for every 4-week cycle. The treatment was continued until disease progression or until toxicity. So this is a consort diagram which shows that roughly around 480 patients were screened. Out of them, only 90 patients were recruited, 45 into the experimental arm and 45 into the control arm. The baseline characteristics were almost similar. There is not much of difference. moving to the results, that primary objective of this study was to look at the overall survival. They met their survival primary endpoint, that they showed that the median overall survival increased to the tune of 2.4 months by addition of nimetuzumab to the gemcitabine, that it improved from 8.5 to 10.9 months with a hazard ratio of 0.50. That means that there is a 50% reduction in mortality by adding nimetuzumab. By per protocol analysis, the magnitude of benefit was roughly around 3 months. Subset analysis, this was just a study consisting of 45 patients in each arm. So I do not see that subset analysis will give any better picture. But however, they showed that those who did not receive those who did not need any kind of therapy for biliary obstruction, they tend to do better with a nimetuzumab plus gemcitabine. Progression-free survival, it was though statistically significant, clinically the magnitude of benefit was very minimal from 3.6 to 4.2 months. Again, subset analysis showed a similar picture, similar to overall survival. The response rates, we all think that more number of drugs may increase the more number of response rates, but it was not the scenario with nimetuzumab. The response rate, objective response rates were similar, but disease control rate improved from 58 to 75%. And even the clinical benefit rate was numerically better in the nimetuzumab plus gemcitabine compared to gemcitabine alone. Safety profile, we all know that anti-EGFR antibody adds a lot of toxicity, both skin and GI toxicity, but scenario is not same with the nimetuzumab. It is not as toxic as cetuximab or panitumab, and as this study reflects that side effect profile is almost similar. Only skin toxicity that increased from 9% to 13%. I think this is quite manageable safety profile. So with this, the study wants to conclude that probably nimetuzumab, when added to gemcitabine, increases overall survival and progression-free survival, but this should be in a very small subset of pancreatic cancer, that is KRAS wild type. And the second important thing is this included only 45 patients, and the standard arm included gemcitabine. The standard of practice is doublet or triplet, not gemcitabine alone. So we do not know how, when nimetuzumab added to gem-nab-paclitaxel or FOLFIRINOX, will it really does the same? So more and more studies probably needed in this KRAS wild type pancreatic cancer to answer further questions. Is it a time for adding targeted therapy even in the pancreatic cancer? With this, I conclude my talk. Thank you.
Thanks a lot, Dr. Shiva. The next speaker is Dr. Jitendra Perlajani. He is a consultant medical oncologist at HCG Cancer Center, Jaipur.
Good morning, everyone. I would like to thank the organizer. Can I have my slides, please? So I am dealing with one of the rare cancer what we have, and definitely neuroendocrine tumor is probably a basket which we have to open as an oncology community, because there are a varied history of the disease which basically depict. So on that line, this phase 2 study I would like to discuss. It's a randomized study, which is a phase 2 done with temozolomide and capecitabine versus plus minus capecitabine in patients with advanced pancreatic NAT. And this is a final analysis. First analysis was published in 2018, and this was by done ECOG ACRIN E2211 study. So coming to the study, as we all know that pancreatic neuroendocrine tumor are epithelial neoplasm, which are derived from nut cells, a subset of which need robust objective responses, because these tumors actually have a wide variety, as we know, that from grade 1 to grade 3, and they can have intermingle histology, and the history basically have much gray zone. So we have to find out the right answers. So as we all know that streptozotocin is only the drug which is basically used for cancers who are pancreatic peanut who are actually endocrinely active, and other agents like sunitinib, everolimus, PRRT therapy, LAR, which we can use for non-secreting peanuts. So on the contrary, if we can see that if we do have data of cisplatin-based therapy on NAT3, and we have CAPTAM as a regime in NAT3. So this study actually ruled into how we can use best of chemotherapy in NAT1 and NAT2. So the proof of principle was that there were small studies in which probably temozolomide was given, and it was provided. As we know, NETR are slowly growing tumor, especially grade 1 and 2. So they found out that the response rate was on the tune of 30 to 40%. And if you add capacitam into it, it was reaching to 70% in few phase 1 or retrospective studies. So as we know that capacitabine may be synergistic work with temozolomide by down-regulating MGMT. So the second subset analysis was pertaining to this, that how MGMT will help assessing which will be the best patient to be treating with the same regimen. So as we know that temozolomide induces DNA methylation at the O6 of guanine, and which lead to DNA addict and damage, and which lead to cell death, which usually inhibited by and repaired by MGMT. So patients who have MGMT silencing in GBM, they are sensitive to alkylating agents. So in NET mechanism, other than methylation also work, but it is less common. Yet MGMT is still lost in many of the neuroendocrine tumor patients. So we have various retrospective data evaluating MGMT as a predictive biomarker in PNET, but the result is mixed. So this was the study design, progressive, as we all know that the patients who are having PNET can be observed. If they are progressive, then only we should treat them, or if they are having symptoms. So here the eligibility criteria was progressive disease, which was having low, intermediate, grade, advanced pancreatic NET, and they have to be stratified by prior everolimus, prior sunitinib, or concurrent octreotide large. So they must have a prior therapy with the 3 approved agent, and they were stratified into 2 arms. Arm A was temozolomide alone, and arm B was temozolomide plus capacitabine, the standard dose what we use in other tumors. So the primary endpoint, as we have discussed, was PFS. Secondary endpoint was response rate, OS, toxicity, and the correlative endpoint was MT by IHC, the H score which we'll discuss, MGT by promoter mutation, and central path review was done. Because as we know that NET is having varied, and it's difficult to grade them pathologically. So these were the statistical consideration. 145 patients were required to obtain at least 138 eligible patients to detect a difference of in median PFS of 9 versus 14 months, which was pre-specified using a 2-sided log rank test by 81% power and a p-value of 0.20. And one interim analysis PFS plus planned at 76% information. Means 80 PFS event, they planned that they will do an interim analysis for futility. And data from the pre-planned interim analysis, as I was discussed, was present at ASCO 2018. And data lockup time was at the interim analysis, which was January 2018. And the updated final analysis, which was published now, was May 2021. And it was presented in this ASCO. So these are the baseline characteristic. As we can see that the number was almost symmetric, and the age was almost same, and it was majorly non-Hispanic population, and the time for diagnosis was slightly lesser for temozolomide subgroup on the contrary to the combination arm. So as we can see that grade 2, which is a intermediate grade of tumor, which is more in the temozolomide arm, and the other thing was almost comparable. So this is the graph which shows that the primary endpoint, which is PFS, and as you can see that the median PFS time was 14.4 months versus 22.7 months, and the p-value was significant with this. But as we can see that that graph are overlapping with each other. But yes, there was definitely separation in the OS curve, because probably the PFS chart was not matching because there was crossover which was allowed and other therapies which were given. So as we can see that median OS was having a 5-month difference, which was not statistically significant, and probably the reason may be because the therapies which was given were on the grade 1 and grade 2. So these tumors basically progress a lesser velocity, and the patient may have time to respond to other therapies. So coming to the objective response rate in the form of complete and partial response, so it was disease control rate was almost 74% versus 84%, and the response duration was almost 13 months versus 17 months. So the side effects are almost similar. As we know that grade 3 for toxicity was higher, but the side effect profile was similar. And treatment continuous rate of and or the tune of 7 to 8%. So this is what they do, that MGMT testing was done in almost 97 patients by IHC. And this is how they are devised. It is grade IHC 1, 2 was low and 3 was high. So almost 50% patients in the response arm was having MGMT low. So this is assessed by MGMT. As we can see that patient who are MGMT low were have better response rate in both the arms. But as we can see that it was slightly better in the combination arm. So this is the pie chart of the same. And we can see that patients who are having, just finish, and the MGMT deficiency was associated with better PFS and OS. And the conclusion was that the regime was efficacious. In the combination, it was well tolerated, and MGMT mutated patient was MGMT low patients were better benefited by this regime. Thank you.
Thank you, Dr. We have some minor alteration. Dr. Lalit Mohan Sharma, who was supposed to deliver the next talk, is not here, I guess. So now we are straight away moving towards the panel discussion part. So to moderate the session, may I invite Dr. Kripa Bajaj. He's a consultant medical oncologist at Indo-American Hospital Institute, Hyderabad. Our esteemed panelists are Dr. Tarachand Gupta, consultant medical oncologist at Bhagwan Mahavir Cancer Hospital. Dr. Moveen Mittal, senior consultant and head of the department at Patiala. Dr. Anu Rajpurohit, consultant medical oncologist, SMS Hospital, Jaipur. And Dr. Amit Shehrawat, assistant professor, Department of Medical Oncology, AIIMS, Rishikesh.
Very good afternoon to everyone. Today we are now we are going to discuss regarding GI non-collateral panel discussion. A very warm welcome to all esteemed panelists. So we are going to discuss regarding 3 abstracts. So one was not presented though, but we'll just take the crux of the abstract in the discussion. One is a notable study. We'll see whether it's a notable or not. And second is ECOG Acrin E2211 study. Just now Mr. Jitendra has presented. And third is Herbie trial. So notable study, as already presented, it's a randomized control study which was used as a first-line therapy in KRAS wild-type pancreatic cancer, randomized to nivolumab plus gemcitabine versus gemcitabine alone. So the sample size was low here. Primary endpoint was overall survival. Secondary endpoint is PFS. The summary and conclusions of the study is the nivolumab combined with gemcitabine increases OS and PFS in patients with KRAS wild-type locally advanced or metastatic pancreatic cancer with the obvious good safety profile. So notable study showed a breakthrough in the treatment of advanced pancreatic cancer, and notable study lightened a new era of target therapy of enriched pancreatic cancer population based on the biomarker. Addition of nivolumab to current treatment regimen will provide benefit and great value to pancreatic cancer patients. Let's see what's the take on this study from our panelist. Dr. Anu Rajpurohit. What are the current treatment options do you offer to your patients who are locally advanced, unresectable, or metastatic pancreatic cancer? First line, second line, third line, tell me.
Okay. So that depends on the patient's age and the performance status. If my patient is young and fit, I offer him FOLFIRINOX. Other options are FOLFOX, then gemcitabine plus capecitabine, then nab-paclitaxel with gemcitabine. So mostly it is gem-based.
So gem-based regimen you're planning. If patient is fit only, you'll move to FOLFIRINOX.
Yes.
Dr. Amit?
Yeah, that actually depends on patient performance score and comorbidities, general condition of the patient overall. So it can be varying from single agent gemcitabine to gem plus nab-paclitaxel to gem plus capecitabine or even modified FOLFIRINOX. So that actually depends on clinical scenario.
Correct. Dr. Tarachand Gupta?
Yeah, I agree with Anu that depends upon the fitness, and second most important is the preference. Either patient is perfect or with a weekly regimen, or he wants to come after 2 weeks. Because I think there was some study, then if we give gem nab-pacli first and then FOLFIRINOX, or FOLFIRINOX first followed by gem nab-pacli, there was no difference in overall survival. So I usually go with the preference of patient where he matters the distance from the hospital and other aspects also.
Points very well taken. Dr. Mubin Mittal, your take on this? What's your preference of options line for a patient with pancreatic cancer who were unresectable and metastatic?
Bilirubin. If the bilirubin is less than 1.5 and the performance status is good and the patient is fit, definitely we will go for the FOLFIRINOX. And if the performance status is 2 to 3 and the bilirubin is slightly 1.5 or more than 1.5, definitely go with the FOLFOX. And if the performance status is poor and patient is age is more than 70 years and bilirubin is more than 1.5 or 2, definitely go with the GEM and NAMPAC.
Anyone tried gem erlotinib in the first line or single in gemcitabine?
Yeah, single agent gemcitabine for some patients like sir said more than 70 for borderline performance score. So single agent gemcitabine is one of the options that I offer.
Gem cap, gem erlo.
Gem erlo not in first line, but actually I tend to add erlotinib only on first line failures.
Okay, so the consensus from all the panelists is first line, they do prefer, as per the age, performance status, they do prefer FOLFIRINOX versus gem-nab-paclitaxel. Again, Dr. Tarachand's point is, as per the feasibility of the patient, gem-nab-paclitaxel followed by FOLFIRINOX as per the patient, if it really feasible to come over weekly regimen. So these are the options in the first line, and like the sequencing also they suggested. No one is interested to use gem-erlotinib or gem-cap, single and gemcitabine in the elderly patients, right? So do you feel this is exciting data to implicate in your practice? Gem nimetuzumab, whatever elderly patients you suggested are very fit patients. Do you feel this exciting data? What are the positives from study you do feel in the study?
What I will say, it's an interesting study, but a small study of 45 in a Chinese population. So immediately, am I going to change my practice? Answer is no. But yeah, this is one of the interesting options that we can offer to limited patients. But for now, immediately Monday morning, I'm not going to offer this.
Monday morning, then what about the next Saturday morning? Will you practice this if any person
I
has
need
come?
more data, especially from our context. Then only I'll be more comfortable offering this. Right now, I'm not comfortable.
Thank you. Dr. Tarachand.
Yeah, I agree with the panelist that still I am not very exciting about the data because there are 2-3 things from where the dose of 400 milligram came, because it is 200 milligram weekly in head and neck. And the second thing, they are doing in KRAS wild type, then why they're not try in the colon also. If the KRAS wild type they want to give anti-EGFR. And third most thing, yes, if this is it comes into the third or fourth line, I may try. If the patient is not fit for the other therapies.
You may try. You're giving a thought to try.
After the third, fourth line, desperate situation, patient is fit, then we may try after.
Instead of using gemcitabine first or second line, you still want to do the combination on third or fourth line.
Third and fourth line, because gem-nab-paclitaxel, FOLFIRINOX, and third line is this. And there is nothing like if I have given gemcitabine, because if you go in the colon, then FOLFOX followed by FOLFIRI is still there. So it is not excluding the 5-FU. So this is the biology and the structure of the agent that may change the response.
But the data is not for the recurrent, like the second line or third line, right? Still you want to use it. Like you may give a try because there are no options.
Yeah, after them, if there is no option, patient wait.
Dr. Mubin Mittal, your take on this?
Ma'am, first is sample size is small. Second thing is cost. Definitely cost of the treatment will increase. And third thing, if the more supportive data in this nimetuzumab plus gemcitabine will come, definitely I can think to start as a first line treatment.
First line itself. Dr. Anu?
Yeah, I agree with my panelists. So first thing, it's very interesting data in the study, but we need to have our own study. And second, cost. But yes, we can keep it as an option in the later.
So no one is so excited about this study, right? If ever in future, lot of sample size is that the consensus is no panelists are excited about the study. After some consensus, after like lot of sample size, they want to implicate in the second line or third line after some data, not now, right? That's your take on it.
Kripa, one more thing. And from audience also we can take who are excited to take this study positive. I think.
I don't see anyone excited. Is anyone excited? Please raise the hands. Like we also, looking forward to that excitement. So anyone doing NGS upfront, mutation analysis upfront in the pancreatic cancer, when you are preferring to do the KRAS mutation testing or NGS testing in pancreatic cancer, start with Anuraj Purohit.
So currently I'm not doing it because we don't have any targeted therapy, but after this study where we find KRAS wild type, we can offer this combination, but till now I'm not offering.
Again, upfront you'll offer NGS if you want to offer, or you want to try like post FOLFIRINOX, Gemnapacli again,
Yes,
like
after
other to do.
progression on the first or second.
So you are not preferring to do upfront NGS.
No.
Dr. Mubin?
NGS is a costly test, and I'm not using upfront. And if the patient is young and I have tried FOLFIRINOX, then definitely for the BRCA, and I can think of NGS testing.
Fair enough. Dr. Tarachan? Polo trial is negative.
Actually,
Still you want to do the
actually,
BRCA
I
test.
don't find any harm in doing NGS upfront, even in any tumor, because sometimes patients come with targeted agents like MSI high and others. I want to share that from my colleagues, very close colleagues group, in GVM at least 2 cases. One was positive for the c-kit. So that patient is on imatinib at present from my one of the colleague and doing well. And another one was positive for the MSI high, and he is also doing very well with Pembrolizumab. So if the patient is ready to do the test, there is no harm, in my opinion, in doing NGS.
Dr. Amit, your take on it. I think you are working in the government sector.
Yeah, so that was the point. First thing, if you go by the guideline, they are actually recommended upfront for all NCCN recommends all those tests, including KRAS, not specific KRAS, but in NGS is as such recommended. But since I am working in a public sector hospital, so I offer this only if patient is affording not just test, but therapy also.
Upfront.
Only if patient is affording the therapy also, not just test. Then I am offering upfront NGS.
The
Otherwise,
consensus, yeah, the consensus for this question is if patient is affording, there is no harm in doing the test upfront. If ever any targetable mutation is there, you'll think to whether to use it or not, target it or not, right? That's a consensus. So how will you place this option in the treatment algorithm? Already you have mentioned, if ever you saw the wild thing, like then you will introduce in the second line, third line, but not in the upfront setting. Dr. Amit, you told you may consider keeping in the upfront setting if there is a more data.
yeah, not right now, but yeah, we need to have more data, especially our own experiences. And one of the genuine concern is about dose also. So there is no rationale of starting, like there is no phase 1, phase 2, specifically in pancreas, they started 400. Even in head and neck, if you go by the data, the 200 milligram was actually better than 400 milligram.
Correct.
So I don't see any rationale of offering 400 milligram weekly for 4 weeks continuous dose. And even though whatever we say nemotuzumab is safe, it's not having toxicity, it has some toxicities. And that will obviously more with 400, because I don't have any experience of offering 400 weekly nemotuzumab.
Great. So the issue with the trial are numbers, population, comparator arm. So the population is exclusively Chinese population. The numbers are very low. That's the main concern for all the panelists. So Monday morning, everyone wants to send NGS upfront if patient is affordable. And if ever mutation, any analysis like came out to be wild type, then you'll implicate the treatment part in the second line, third line, maybe in future first line. That's the consensus regarding the study from all the panelists. So chemotherapy is still the main treatment. If you see this here, so gemcitabine alone versus Gemnapacli, 8.7 months is there. So if you see the PFS of this study, it's very promising in the wild type people. So maybe in the second line, I mean, I'm also like person who will pro to this treatment, like in the second line, FOLFIRINOX 11.5 months versus 6.8 months. If you see this study, so there is a decent amount of PFS and OS is there. Patient has a almost equivalent benefit like FOLFIRINOX. So definitely this can be in the second line. After few data, we can't implicate in the practice. Maybe in the future, after a lot of recruitment, Gem plus nemotuzumab versus FOLFIRINOX in the Indian population, if you see, which is better, the sequencing, lot of data has to come to implicate this in the practice. So it's a small trial, Chinese population, wild type is very uncommon subtype because a lot of Indian patients, Tata Hospital analysis is there, almost 60% are having a mutation positive. It's not so practice changing as of now. Proof of principle study, yes, there is a benefit of nemotuzumab wild type. Comparator arm will always remain an issue. Single and gemcitabine versus Gemerlo, maybe Gemerlo might be a better comparator arm if we want to compare it properly. Toxicity is manageable though. Current treatment options continue to remain mainstay for now. Biomarkers is a happening field in the pancreatic cancer. Coming to the next one, it's really exciting for me because CAPTEM almost all of us are using from ages. So still they want to test on it. This study, they saw the low intermediate grade neuroendocrine pancreatic tumors. Prior everolimus, prior sunitinib is allowed. They got randomized to temozolomide single agent versus K plus TEM. And primary endpoint is PFS, secondary endpoint is OS. It's just reverse of the thing. And correlative endpoints, MGMT by IHC and promoter methylation analysis. If you see here, the histology, the low grade versus intermediate grade, like almost equal distribution is there in CAPTEM, slightly higher, low grade PNADs were noted. And WHO grade 2, histological grade, if you see 62% versus 49%, slight discrepancy is there in the distribution. Apart from that, almost all subgroups are bang on nearly. The conclusions of the study is CAPTEM demonstrates a significant improvement in PFS compared to TEM. That's 22.7 versus 14.4 months. There is a clinically meaningful trend towards improved OS, though it did not reach statistical significance. RR is high in both arms compared to most approved therapies. That's 40% versus 34%. Like whether we'll discuss whether it's really significant with our panelists. The combination of CAP and temozolomide should be included as a standard treatment option for patients with advanced PNETs, as already we do. And it's a reasonable comparator in future randomized trials. For suppose if you want to see the new standard, if you want to test some new standard, CAPTEM is definitely a better comparator arm. And MGMT deficiency is significantly associated with response to TEM. We have observed the trends of MGMT deficiency associated with improved PFS and OS. So what is the current options for your patients? Dr. Anuraj Purohit, grade 1, grade 2, low key 67. What are the options? First, how will you evaluate, like what options you will provide?
First of all, I have to see what the size of the lesion and where it is located.
It's pancreatic one, head of the tumor.
It is not resectable.
Unresectable.
So we have many options. If it is grade 1 only, slowly progressing, then octreotide, sandostatin, and then other option sunitinib, everolimus. And if the grade is 2, it is the rate of progression with time is high, then I'll try to offer 10 plus K.
So how will you sequence it? Like in the sense, your options and your sequencing. Upfront, you want to start with sandostatin.
Yes.
Post scan, you want to see SSTR expression and you want to start with sandostatin. Later, you will sunitinib, everolimus, everything will come into picture.
Yes.
Where you keep CAPTEM?
That depends on the biology of the tumor. If it is rapidly progressing, then yes, CAPTEM is my option.
Dr. Mubin Mittal?
Definitely after the mitotic index and the Ka67, if it is grade 1 and unresectable, then I will start with the somatostatin analogs, and then definitely the sunitinib and lenvatinib is the another option, and then the CAPTEM is the another option.
No, don't tell all the options. I'll say PRRT is an option. What is the sequence of your therapy?
Somatostatin analog followed by the sunitinib, and I will keep this as a fourth line.
Fourth line. Third line?
After lenvatinib.
After lenvatinib. Where do you keep PRRT therapy?
After progression.
It's fifth line. You want to keep it fifth line?
Grade 3 and after progression on the somatostatin analogs. Actually, PRRT therapy is not available in the peripheries, and cost is definitely an issue.
Okay. Dr. Tarachan?
Yeah, actually, if the patient is symptomatic, then I would like to treat the NET grade 1 or grade 2, or it is going to be critical in the future if it increases in size. Otherwise, if the patient is asymptomatic, then I will not treat the patient, will observe only. And if I am taking the decision to treat, then I will see the data uptake also. And if data uptake is significant, then the PRRT will be the first option from my side. And if not, then sandostatin or long-acting octreotide. Second, after that, I can take everolimus. And if the patient is not data showing, and then CAPTEM is a good option, and we are treating the patients since last 7-8 years with the CAPTEM.
Points taken. And what about if patient is not having any secretory symptoms but still having a large, huge mass, you will treat it or not?
Yeah, I already mentioned that if the patient is in future going to be critical, like the liver size increasing, and at that time patient will not left any treatment option. So I will treat the patient. But the sizes are small, even multiple. then I will wait.
Dr. Amit?
Yeah, I agree with the sir. So this actually depends on not just histopathological or tumor things. It's more about clinical scenario. If patient is having limited disease burden and patient is asymptomatic, then observation is one of the preferred options. If patient is having high disease burden, still asymptomatic, and we think that in future patient will have some issues, then we can upfront start Sandostatin. And Sandostatin is also obviously that depends on molecular imaging, whether that is positive or not. That's the first thing. And if it's positive, then by default, I think every one of us are offering Sandostatin LAR upfront and followed by other subsequent options later on. Yeah, Captem, majority of us are not offering in first line, but we understand a limited small group of the patient, those who are presenting with high disease burden and actually symptomatic, this is one of the first line treatment option as of now. So that is already there, that evidence is already there. Even last year, there was a comprehensive review in Journal of NCCN published in December of 490 plus patients. That is also establishing this as one of the most suitable option for this group of the patient, at least in second line, third line option.
So where you want a rapid response, you want to start Captem.
Not for all patients, but a small group of the patient with high disease burden, patient is symptomatic and we want a rapid reduction. That means it can be one of the option in grade 1 and grade 2.
So do you think it's a practice changing to implicate? It's already changed your practice, so you don't see any practice change in this by this trial?
I think it's reaffirming that whatever we are practicing.
Correct. So this is the ESMO guidelines. In this one, if you see grade 1, grade 2, the same, almost the similar sequence. Sometimes it can alter. Streptozotocin no one is using because of the toxicities. So we have lack of time, so I'll just conclude this. So it's a positive study. Long PFS rates are there. High response rate, that's 34 versus 40. But OS is not so significant. Whether to use temozolomide single agent versus Captem is a question. But all of us are agree with, we are happy with using Captem. And one more thing I want to ask panelists is, do you implicate MGMT testing in the management of, before introducing temozolomide, just like GBM you want to introduce? Dr. Mubin Mittal, you can answer this question. You want to do MGMT testing before temozolomide for all cancers like GBM?
In any neuroendocrine tumor. I have done in the GBM tumors, but not in the neuroendocrine tumor.
Dr. Amit?
No experience.
Great.
Offering in clinical practice, but yeah, this can be one of the sort of a research topic for our patient.
Yes, a lot of papers have come from India, like IHC versus MGMT promoter methylation in all the cancers where temozolomide is using. There is no concordance and not much use is there except the GBM, though this is some correlation in the study, but a lot of data yet to come. So the HER2B trial, the person hasn't discussed. I think Dr. Lalit Mohan Sharma was supposed to get discussed this one. This unresectable biliary tract cancers, it got randomized to Trastuzumab deruxtecan versus external control group. Other trial is that if they're ineligible, they're automatically taken into Japanese registry study, other trial. And the patient is HER2 positive or HER2 low, both are included in the study. Let us see the result of this study. It's a single arm trial. So in this, as I told, positive, low expressing, negative, everyone got included, whoever are biliary tract cancers, detected with the biliary tract cancer in March 2019 to 2020. So what are the primary endpoints? Confirmed overall response rate. If you see HER2 positive, definitely there is a response rate, 36.4%, but still HER2 low, still the low patients also got 12.5% response, though the numbers are not as staggering as the breast cancer, but there is some response is noted. Overall, all patients, it's 30% response is noted. So conclusions of this study is it showed a promising activity. The confirmed ORR of 36.4% with median duration of response 7.4 and median PFS of 5.1 months and median OS is 7.1 months in HER2 positive unresectable recurrent biliary tract cancer. The signs of efficacy among HER2 low expression patients were also observed. Although this study did not identify any obvious risk factors, interstitial lung disease requires careful monitoring and intervention. Further explorations are needed to confirm this study. So, Dr. Amit, what's your take on this study? Are you routinely using HER2 testing? Already there is a data from AIMS is there. Are you, Dr. Amol Patel has published the data. So, are you routinely performing HER2 testing on the biliary tract advanced cancers?
Actually, that is being done as a part of a project, but for a clinical decision making, we are not, because I am practicing in a public sector hospital. Most of the patients, they are not affording transplant for breast cancer. So obviously they are not affording for atypical sites like biliary. More important point is most of the patients, they present with heavy disease burden. They present with obstructive jaundice. They present with PS3 and 4. So actually those things are sort of a contradiction or sort of exclusion criteria for this particular trial. So yeah, this is one of the promising data, one of the promising study for future for a small select group of the patient in our clinical practice, not for all, yeah, by default, not for even all those who are HER2 positive.
The duration of response is 7.4 months. You want to implicate this in future practice if it is affordable, right?
Even with cytotoxic chemotherapy, the median PFS is 5.2 months, 5.4 months. So I don't think that palliative setting where we are not expecting survival even beyond 1 year, just adding 1.5 month, I don't think that's going to change practice.
Dr. Tarachan, your take on this study, and like, do you recommend routinely HER2 testing in advanced biliary tract cancers?
Not only HER2, usually I said that I prefer NGS if the patient is willing to afford the medicine in future and test also. Otherwise, especially HER2, I am not doing it presently.
So
And
wherever HER2 positive, you're using trastuzumab routinely, like in your practice, if it is positive.
no, trastuzumab is usually if we see in the other tumors that it is not so good like lung cancer and others. Still, the TDM1 is yes is doing good in HER2 positive other cancer and other. So I will if it comes positive and I have to use the medicine, then I will go with the TDM1 because TDXD is a new molecule for me. I have not used till now.
Dr. Mubin Mittal, are you routinely using practicing NGS and HER2 testing?
Definitely, I am doing HER2 testing if the cost is not an issue. And we are using trastuzumab along with the doublet-based chemotherapy.
You're using the combination.
Yeah.
So if patient is having deep pockets, will you introduce trastuzumab deruxtecan to the patient in the first line or second line?
Definitely according to the availability and the cost. Cost is not an issue and it's available, then definitely we will.
Dr. Anu?
Yeah, I agree with the panelists. So it gives us an extra option for the patients. And regarding NGS, yes, we should do it if patient is affordable for the targeted therapy later on.
So the take is if patient is affordable, they want to introduce, some panelists want to introduce trastuzumab combination upfront. Some want to use the TDM1 if patient is HER2 positive in the second line. If patient is having deep pockets, definitely they introduce this option to the patient. That's the consensus. Monday morning, they're not going to change the practice with trastuzumab deruxtecan for sure because it is highly impossible to most of patients to afford. So this is NGS is definitely everyone accepts that majority of solid tumors, it's a way to go in metastatic setting. If any mutation or any target is there, all of us are willing to target that. With this, I conclude my session. I think already I'm running late. Advanced BTC is a challenging disease with limited options. HER2 positivity around 14% is noted. That's AIMS collaborative study, AIMS as well as Tata Memorial Hospital consensus. Small numbers, though large numbers were screened, Central Path reviews the strength of this study. There's a lack of comparator arm, as already one of the panelists told, first line with chemo also, they're getting a very good PFS of 7.4 months. If they introduced other options, you would have get the better answers. The CR and PR rates were observed in a patient who are HER2 positive. Definitely, that's a good thing. 36% response rate is meaningful, though it's less than expected 40%. PFS is definitely meaningful in HER2 positive. There is some response in HER2 low, but still it's not acceptable like a breast cancer. No one can give standing ovation to the study. And signal also observed in HER2 low status, as I already told. Large studies in prospective manner would be indicated with a better comparator arm. Interstitial pneumonitis remains a concern considering the high numbers. Because it's low, we didn't see anything, but if high numbers got recruited, definitely would have seen something. And it will be interesting to understand long-term responders, parameters as anatomical site, HER2 positive score as well as other biomarkers. Additional studies warranted in this regard for concrete conclusions. I thank organizers and my esteemed panelists for chairing the session. Thank you.
Thank you. Thank you, Dr. Kripa Bajaj and the esteemed panelists for the nice discussion. And now I invite Dr. Deepak Shukla. He is consultant medical oncologist, Manipal Hospital, for his next talk on immune checkpoint inhibitors on GI cancers.
Can I have? Yeah, good afternoon. I'm going to speak on immune checkpoint inhibitors in first-line gastric cancer, gastroesophageal cancer, and esophageal adenocarcinoma. So at the outset, I'd like to thank DMS and the organizing team for giving me this opportunity. So gastroesophageal cancer is actually three distinct entities. So in the esophagus, we have the most common histology in terms of squamous cell carcinoma, while approximately 10% or 11% are adenocarcinoma. The PDL1 expression in esophageal squamous cell cancer is close to 50%. And this disease pattern or the site is more common in Eastern Asia, South Central Asia. While in the GE junction, the most common histology is adenocarcinoma. The treatment for gastroesophageal junction cancer is an overlap between that of esophageal adenocarcinoma and gastric cancer, and worldwide the incidence of gastroesophageal cancers is increasing. The gastric cancer is the most common histology. We all know that it is adenocarcinoma, and overall worldwide distal non-cardiac cancers are decreasing, and the PDL1 expression is variable, ranging from various studies to 25% to 65%. If we look into the Globocan data recently, in India, gastric cancer is the sixth leading cancer, and it is the sixth leading cause of cancer-related death in India. It is along with esophageal cancer, which is at fifth position, and it is also fifth leading cause of cancer-related death. And both gastric and esophageal cancers, adenocarcinomas, are having high mortality. The risk factors, if we discuss, it is mostly similar. It includes a combination of diet, high in salt, less vegetables, alcohol, tobacco consumption. There is an association with obesity. For gastric cancer, there has been shown that H. pylori is a risk factor, while GARD and other precursor pathological conditions are risk factors for gastric cancer. We all are aware that this is the TNM classification. My talk will be restricted to the stage 4 disease. And one of the main reason why the overall outcome for stomach adenocarcinoma or gastroesophageal junction or esophageal adenocarcinoma limited outcome or poor outcome is because majority of our patients present in either a locally regionally advanced stage or present with distant metastasis. These in total account for approximately 75% of the patient. And the current treatment options for these patients with metastatic disease are prior to immunotherapy was usually a doublet or triplet chemotherapy. So the metastatic gastric cancer and gastroesophageal adenocarcinoma, we all see in the clinics, good number of our patient, approximately 10 to 20%, are presenting at a very poor performance status, and some of them are not even candidate for any form of systemic treatment. For the remaining patients who are having a good performance status and are subsequently worked up, if affordable or as per their means the disease course, the HER2 new testing, PDL1 testing, and MSI testing by PCR or MMR testing by IHC should be done. And if a patient is found to be fit for systemic treatment, prior to IO era, it was 2-drug cytotoxic chemotherapy or a 3-drug cytotoxic chemotherapy. The 3-drug was particularly reserved for very fit patients, and majority of our patients received 2-drug combination chemotherapy. So just a word on the biomarkers. The PDL1 prevalence, as previously discussed for esophageal squamous cell cancers, it is close to 50%. While for gastroesophageal adenocarcinoma and gastroesophageal junction cancer, it has been reported close to 24 to 38%. The prognostic value is not clear. The predictive value, as I'll be discussing, it predicts the CPS score predicts the benefit from the immunotherapy. For HER2, again, the prevalence is close to 15 to 20%. The prognostic value is not very clear, and we are aware from the data from the TOGA trial that it adds to survival and also response rate when trastuzumab is added to chemotherapy. MSI high group is a very small percentage, close to 4% to 22%, depending on the patient population that was analyzed. Again, the prognostic value is ambiguous, while the predictive value, as we know that in the second line, we have, as such in solid tumor, we have an approval for Pembrolizumab across irrespective of gastric cancer or gastroesophageal junction cancer prior to this study. So the method how we test PDL1 is either do a tumor PDL1 score, the TPS score, which is we are commonly using in lung, while the CPS score, which is mostly used in the gastroesophageal and some other sites like urinary bladder cancer. So the basic difference is in the CPS, we are taking into account both the tumor and the tumor associated immune cell PDL1 expression as a ratio to the total percentage of viable tumor cells, and thus CPS score is calculated. So we are all aware of the basic mechanism. Basically, immunotherapy prevents the tumor cell for hiding by inhibiting the PD1 or PDL1 pathway. And the T cells and the immune cells are able to recognize the tumor cells and able to kill the tumor cells, which is a mechanism different from chemotherapy, which is directly cytotoxic. So the reason why we are discussing this today, because of this Checkmate 649 study. This was a study that led to approval not only in US or Europe, but in India in gastric cancer, gastroesophageal junction, and esophageal adenocarcinoma. And this study looked into the combination of Opdieta in combination with fluoropyrimidine and platinum-based chemotherapy for treatment of patients with advanced metastatic gastric cancer, gastroesophageal junction cancer, and esophageal adenocarcinoma. So Checkmate 649 was the largest positive phase 3 study in the first line in the patients with advanced upper GI cancer. This was a randomized open label phase 3 study of Opdieta in combination with Folfox or Capox versus Folfox or Capox, which is the current doublet standard in gastric, gastroesophageal junction cancer and esophageal adenocarcinoma. And patients with a good performance status with no known HER2 positive status, and close to 800 patients were randomized to either Opdieta with Capox or Folfox at 2 weekly or 3 weekly regimen versus the standard of care then Capox or Folfox. And the dual primary endpoints were overall survival and PDL and PFS. And these were the other secondary endpoints. If we look into the statistical design of this trial, this trial had an hierarchical testing. So if OS in the PDL1 CPS greater than 5 population was significant, subsequently overall survival for PDL1 CPS greater than 1 was calculated, and followed by OS in all randomized patient was tested hierarchically. If we look into the baseline characteristic, if we look into the population of PDL1 CPS greater than or equal to 5, there are 473 patients, 482 patients in both arms. So roughly 60% of the patients were having PDL1 CPS greater than 5, and most of these patients were males in the and white, and these patients were majority in this trial was gastric carcinoma, while next common was the gastroesophageal, and nearly 12% were esophageal adenocarcinoma. The other patient characteristics, if we look, approximately 4% patients in this trial were MSI high, approximately in both arms, and the use of Folfox or Capox as the partner chemotherapy was nearly equal. So what this trial showed that at the updated follow-up of close to 2 years, the combination of Opdieta with Folfox or Capox demonstrated OS benefit. So initially, as mentioned, the PDL1 CPS greater than 5 cohort, it showed that at 2 years, 31% patients were alive as compared to 19% in the standard of care arm, with a median overall survival that was close to 14.4 months in the Opdieta arm as compared to 11.1 month in the Folfox or Capox arm, with a significant hazard ratio of 0.7. Subsequently, after this data, the all randomized ITT population was tested, and it showed that in the overall population, 13.8 months was the median overall survival, which was 2 months more as compared to the standard of care arm. And in this all randomized patient, the 2-year overall survival was close to 28% versus 19% in the standard of care arm. If we look into the PFS benefit, again, PDL1 CPS greater than 5 had a clear cut extra benefit, we can say. So there was a PFS benefit of close to 2 months with a significant hazard ratio of 0.70. If we look into the all randomized patient, the benefit got smaller, but still was significant. And again, this longer follow-up showed that irrespective of the PDL1 CPS score, the benefit was seen in all randomized patients. If we look in terms of overall response rate, because we know that stomach cancer, gastric cancer is a highly symptomatic disease. So again, response rate is one of the reasons why I may look to choose a particular drug. So it is impressive to note that approximately 11% got a CR in all randomized patients. The response rate was 58% with Opdita as compared to Folfox, in which it was 46%. If we look into the small subset of patients who are MSI high, so the MSI high was a small population, but the median overall survival was very impressive. It was close to 38 months in the MSI high population as compared to 12.3 months. The MSS population was, though the benefit was significant, the magnitude of benefit was small. Though the response rate, if we look both in the MSI high and as well as in the MSS, the response rates were better in the Opdita arm. If we look into the pre-specified subgroup, almost all the subgroups seem to benefit with the addition of Opdita to Folfox. Also, it can be seen as already mentioned in the MSI high subgroup, the maximum benefit was seen. Barring a few subgroups, almost all subgroup benefited. But in the Indian context, one must note this data also. Though the approval in FDA, if we look, it is approval for Opdita irrespective of the CPS score. In EMA, in Europe, the approval is for patients who are having CPS greater than 5. In India, the approval is for unselected population. So if we tease out the data, this data was requested by the FDA for see how the benefit was for patients who were greater than 5 or less than 5. So if we see the magnitude of benefit in CPS less than 1 was lower, possibly, and it was not significant also. But again, this data was not a pre-planned analysis. But in the Indian context, when we are choosing a patient, I think if we do not, if this is the subset, we can omit the use of Opdita in combination with Capox. Again, this has been already discussed that the response rate was better in the all randomized patients, as well as the duration of response was longer. If we look into the overall population in terms of the progression, so most common reason of stopping the treatment was disease progression, and nearly 42% patients received subsequent treatment after completing this planned treatment. The subsequent immunotherapy was used in close to 8% patients in the Folfox arm as compared to 2% in the Opdita containing arm. The predominant treatment that was subsequently received was the systemic treatment, and most of the time it was systemic chemotherapy with taxane, 5-FU or platinum based, and targeted therapy like ramucirumab. And this longer follow-up showed no new safety signal for the combination of Opdita with Folfox. The most common grade 3-4 treatment-related adverse events in the Opdita Folfox arm was neutropenia, decreased neutrophil count, anemia, while for Folfox and Capox, as expected, it was neutropenia, decreased neutrophil count, and diarrhea. If we look into the immunological etiology as a side effect, again, it is reassuring that with the addition of Opdita to Folfox, the overall grade 3-4 side effects were seen in less than 5% of the patients. And in terms of magnitude, gastrointestinal side effect, followed by hepatic, followed by skin, followed by pulmonary and renal were the common side effect. So again, very few were grade 3, grade 4. When we are treating an advanced metastatic disease, quality of life is one of the important reasons for selecting a treatment which we are choosing. So this is the summary of the various quality of life measures that was evaluated in this trial. So the use of Opdita with Folfox lead to prolonged time to symptom deterioration as compared to Capox. Time until definite deterioration was also improved when Opdita was used with Folfox, and the time of improvement was relatively early as compared to when looking to Folfox or Capox alone. The other measures like time to definite deterioration were also better when Opdita was used. So this data lead to the approval of Opdita in combination with Capox or Folfox. And we all are aware that it can be given as 240 milligram in combination at a 2-weekly regime, or 360 milligram 3-weekly in combination with the Capox regime. So to summarize this talk, the Opdita is the first PD-1 inhibitor to demonstrate superior OS PFS in combination with Folfox or Capox versus Folfox or Capox alone in previously untreated patients with advanced gastric cancer, gastroesophageal junction cancer, and esophageal adenocarcinoma. It showed superior overall survival benefit with close to 30% patients being alive at 2 years, higher response rate at compared to the standard of care arm with 11% CR, no new safety signals, and it also improved the patient reported and quality of life data. And longer follow-up data, which I have discussed, further support that possibly in a CPS greater than 5 patients, this is one of the standard of care and should be given to whichever patients who can afford this. Thank you.
Thank you, Dr. Deepak. Now the house is open for questions or any comments, if any. So I think if there are no comments or questions, we'll go to the next talk, which is by Dr. Vishwanath. He is consultant medical oncologist, Apollo Hospital, Bangalore. The talk is on mapping ideal sequencing of drugs in management of metastatic CRC.
Yeah, good afternoon, everyone. And thank you so much, Dr. Sandeep and the other organizers for giving me this opportunity to give this talk. So my talk is on mapping ideal drug sequencing in the management of metastatic colorectal cancer. So as we know, colorectal cancer is the third most common cancer in males and the second most common cancer in females, with a huge incidence of close to 2 million new cases and around 1 million deaths in 2020 worldwide. It represents around 10% of the cancers and also is a significant cause for mortality. And 20% of patients with colorectal cancer, as we know, have metastasis at the time of diagnosis, where around 50% of them who initially had local disease may go on to develop metastatic disease. The prognosis of patients with metastatic colorectal cancer has significantly improved in the last 20 years, and there has been advent of several new drugs. However, as we know, metastatic colorectal cancer in most cases is a non-curable one. So colon cancer is not one disease, it's more than one disease. As we know, anatomically, there's now a lot of data between right-sided and left-sided versus rectal, young versus old. And there is also growing data of the stool microbiota. And then molecularly also, we know that there's MSI high, MSI stable, wild type, KRAS, RAS extended versus mutated. And then we have HER2, and then the BRAF wild type versus mutant. And we also know that there is a molecular heterogeneity by sidedness, significant use of NGS and other molecular panel. We know that the right-sided colonic cancers have more of RAS mutation and MSI high, and then the BRAF mutation. And if you see the left-sided, it's more of a RAS wild type, and then HER2 amplification. And so is the case with rectum. So what influences treatment choices in metastatic colorectal cancer? It's not one thing, it's the multiple things which are involved. It's the patient characteristics, so comorbidities, fitness for chemotherapy, any prior use of adjuvant treatment. The age of the patient is definitely a characteristic which has to be taken into consideration, and then the performance status, and then the molecular characteristic like like what we mentioned, and the tumor characteristics, the tumor burden, whether it is resectable, and then the tumor location is also important. And of course, the patient preference, quality of life, and toxicity. All these things have to be taken into consideration and then tailored treatment accordingly. So we do know, we have listened to several previous talks about the NGS, use of NGS. So now there is a whole lot of genomic landscape which has come into existence. And then we know that there is significant number of patients who can have one or the other mutation. And then we can probably use these targeted therapies and customize it. And so is the case of personalized medicine. Now, principles in metastatic colorectal cancer. So there is an induction strategy, optimal systemic treatment, And then depending on response, if it is a multiple sites or if it's an oligometastatic disease, if it's multiple sites, post-induction strategy, whether you want go for de-escalation maintenance or discontinuation based on the Optimox trial, and then re-challenge or second line. These are the different aspects which we will be discussing now. So going on to the RAS wild type microsatellite stable metastatic colorectal cancer, does anatomical site matter at all? So we do know from various trials, and this last study which was published in 2017 from different studies based on whether it is left-sided or right-sided, and we know that left-sided tumors which are RAS wild type, they significantly benefit with the EGFR partner as compared to the right-sided tumors, which benefit more with the bevacizumab plus chemotherapy. And this was also shown in the FIRE 3 data, the FOLFIRI plus bevacizumab or cetuximab. We know that the PFS and OS by tumor location, we know that it was much better. If you see the OS here, left-sided tumors had benefit with the cetuximab plus chemotherapy arm. You can see a very impressive hazard ratio as compared to right-sided tumors, which benefited more with bevacizumab. So this is the latest study which was published, presented in ASCO 2022, whether the sequence matters. KRAS wild type patients, metastatic colorectal cancers, unresectable. So initial cetuximab plus chemo, followed by bevacizumab plus chemo, or the Optimox plus bevacizumab, and then followed by a stop and go approach, and then followed by FOLFIRI plus bevacizumab, and followed by anti-EGFR antibody. And what you can see here is that the sequence does not matter. You can see that the hazard ratio was 1.03 for the duration of disease control. And you can see that the OS is also not statistically significant. This goes to show though that the sequence does not matter even with the wild type RAS. So looking at the various studies, so the CalGB study, the PEAK, FIRE 3, Paradigm, Strategic. So all goes to say that the OS is better in RAS wild type left-sided tumors with the EGFR plus partner chemotherapy. So you can see that in right-sided tumors, of course, the situation is little different. Chemotherapy plus bevacizumab versus chemotherapy plus anti-EGFR in RAS wild type. In the right-sided tumors, you can see that this forest plot is showing all favoring towards chemotherapy plus bevacizumab. Yes, of course, there are certain situations where we could use anti-EGFR, especially when the goal is tumor shrinkage, and especially in patients who have got a high tumor burden. So now the next question would be triplet versus doublet in RAS wild type. So this was the triplet study which got presented recently at the ASCO 2022. Again, patients with unresectable RAS and BRAF wild type metastatic colorectal cancers, treatment naive, metastatic disease, good performance status. Patients were randomized to modified FOLFOX3 plus panitumumab versus the doublet of FOLFOX6 plus panitumumab followed by maintenance. And the primary endpoint was overall response rate, and the secondary endpoints were progression-free survival. And you can see that there was not much benefit with the use of the triple drug regimen. And you can see that the p-value was also 0.277. So it did not meet the primary endpoint, and the intensification of first-line therapy with the triplet did not improve the overall response rate as compared to the doublet. And not only that, the OS data is also immature, and this may not be the standard of care in this kind of situation. So what about the chemotherapy intensity with anti-VEGF in RAS mutated and a wild type? The RAS mutated or the right-sided and right-sided tumors. And these were the different trials: the TRIBE trial, the Olivia trial, the CHARTA, STEAM, and TRIBE2. All these go to say that in patients with right-sided RAS BRAF wild type or RAS mutated on the right side, and on the left side also, when the patients have got RAS mutation, you can see that there is benefit with the use of triple drug regimen. And you can see these hazard ratios of 0.44, 0.8, and 0.85, where there is some benefit with the use of the triple drug regimen. Now, a few words about the oligometastatic disease. I know it's again a different topic and it's a whole lot of data coming in. But again, depending on whether the patient is, if it is resectable, maybe the patient go for surgery. And if it is like borderline resectable, maybe you could go for FOLFOX. And then if there's a bad disease and you still want to use some conversion, and I think now there is data with the use of bevacizumab along with chemo, and also panitumumab or cetuximab. This was the Cairo-5 study design, and which was again presented at ASCO 2022. Patients with potentially or unresectable disease And based on the RAS mutation and all that, and patients were again treatment naive with only liver-only metastasis, were randomized to receive especially the right-sided primary and FOLFOX or FOLFIRI plus bevacizumab, or the triplet plus bevacizumab. And you can see that the maintenance, and the other arm was actually the left-sided primary with RAS wild type. And again, they were randomized to FOLFOX or FOLFOXIRI plus panitumumab or the bevacizumab partner. And what you can see here is that the triplet drug regimen did give some PFS advantage and a hazard ratio of 0.77 and a statistically significant p-value. And the OS data is not mature yet. So this was the first prospective trial evaluating systemic induction regimens in patients with unresectable metastatic colorectal cancer with liver-only metastasis. And in these kind of patients, that's definitely in the RAS mutated primary tumors, triplet chemo plus bevacizumab was associated with efficacy improvements as compared to the doublet. So, and then there is also this conversion therapy in the wild type. There's a phase 2 trial called the WOLFI trial, FOLFOXIRI plus panitumumab. Very good overall response rate of 87% and higher R0 resection. Like I told previously, maybe this could be considered in patients who are young, who are able to tolerate this triplet, higher tumor burden, and maybe highly symptomatic disease. So what do we do if the patient has got in metastatic colorectal cancer? The next thing you want to do is kind of de-escalation to maintain. So what is the data for maintenance? So in RAS wild type, we have the recently published the Panama trial, where they looked at FOLFOX plus panitumumab, and patients who had at least a stable disease went on to receive panitumumab plus 5-FU-leucovorin or just 5-FU-leucovorin. So what was seen here is that there was some PFS benefit in patients who are on 3 months of PFS benefit in patients who had the panitumumab maintenance along with 5-FU-leucovorin. Of course, it's difficult to get an OS advantage with this. So similarly, the Cairo 3 trial looked at maintenance capecitabine plus bevacizumab versus observation in metastatic colorectal cancer. And what you can see, again, there was a benefit with almost a 4.4 months benefit with the PFS in PFS1 with the maintenance, and then PFS2. And of course, OS is not, and the quality of life is maintained, no OS advantage. So, and then looking at what if the patient has MSI high in the first line? Do we have data? Yes, we do have data with the Keynote 177 first line Pembro versus chemotherapy in MSI high metastatic colorectal cancer. You can see that there was a significant PFS advantage and the hazard ratio of 0.59. And again, if you look at the OS, median OS is not reached, and you can see that the p-value was 0.03 and the hazard ratio of 0.74 for the OS. So this is definitely on the cards for patients who have got MSI high. Like this previous speaker mentioned, in GI malignancies, we generally get like 4 to 5% of patients with MSI high. And then is there data for Nivo plus EP? Again, there is a phase 2 data of Nivo plus EP. And again, very good, decent response rates of 69%, which is more or less like equal to a triplet when we give. And this is impressive response rates, and 24-month PFS of 74%, which is also impressive, and 24-month OS of 79%. So based on whatever we have spoken so far, again, in the right-sided hemicolon, so it is probably as far as possible. I mean, if the patient is fit, we could use triplet there, since there is a lot of data, and plus bevacizumab, and alternatively, I mean, you could use a doublet. But in KRAS wild type, definitely in the right side, you could use bevacizumab. But if you want a deeper response, of the patient has got a highly symptomatic disease, maybe you could use EGFR blockers. But MSI high, again, checkpoint inhibitors, and BRAF mutated, you could use chemo doublet plus bevacizumab. So, and in RAS wild type left-sided, I think the verdict has been there for quite some time. It's chemo plus doublet plus anti-EGFR. And second and subsequent lines, I think it again depends on the treatment goal, and what about the disease factors and patient-related factors, biomarkers, and what are the tumor agnostic markers which you've got positive, and several other factors, and also how much toxicity the patient has, premorbid conditions. All these things matter. And if the patient has had a good time from discontinuation since the first line therapy, and if the patient has had a very good response, and if the patient has had no maintenance, or if the patient has had very little toxicity, probably you could go back to the first initial regimen. Of course, if the patient has had not much of response, and there is a lot of toxicity, then maybe you could go for a second line regimen. And this is something which we have discussed. And this is the Beacon study, which looked at Encorafenib plus cetuximab plus or minus Binimetinib. And you could see here that especially in BRAF mutated patients, you could see that the triplet, that is the 3-drug regimen versus the doublet, there was not much difference, but there was benefit definitely as compared to the control arm, good hazard ratio. So definitely in BRAF mutated patients, this combination could be used. Now, what about HER2 amplification? HER2 amplification in various studies is in the tune of around 4%. And as we spoke previously, it is more common in patients with the wild type RAS and extended RAS and PI3K wild type. So, and I just wanted to mention this, that though HER2 positive HER2 inhibitors are mainly used in the second line and subsequent lines, but it could be used in as per the NCCN guidelines and the up-to-date. You could in patients who have not very fit for intensive therapy, if you see here trastuzumab plus pertuzumab plus lapatinib could be considered in the first line setting as well. So these are the different studies. The My Pathway study, which looked at trastuzumab plus pertuzumab, and a decent overall response rate of around 31% in RAS wild type. And then the Heracle study, which looked at trastuzumab plus lapatinib in previously treated, multiply pre-treated metastatic colorectal cancer, again a response rate close to 30%. And then the Mountaineer study, which looked at tucatinib plus trastuzumab, again a very good response rate of 55%. And then we have the Destiny colorectal cancer 01 study, which looked at the TXT. And again, if you see very good responses. So, and this is definitely the new drug, which is probably going to, from the later lines, maybe slowly shift to the first line in a few years from now. The sotorasib and the adagrasib, especially in patients who got the KRAS G12C mutation positivity, definitely this is on the cards, and this is definitely going to come up in the future. And what about larotrectinib? Again, the tumor agnostic marker, the NTRK fusion, very good response rates in several malignancies, and colorectal cancer is also not an exception. And similarly, the entrectinib also has got very good responses. And if you see the dark blue ones are the colorectal cancer, and you can see that there is good responses in patients who got NTRK fusion gene, but unfortunately it's not very common, and this drug is not available in India yet. What about regorafenib? This has been there for quite some time, but we're all worried about the toxicity with the use of 160 milligrams. I'm sure all of us, bring down the dose at 80 milligrams, give 2 weeks, 3 weeks on, 1 week off, all that we do with significant mucositis and hand-foot syndrome, hypertension. But yes, there is some amount of OS benefit, but not very modest. And this is the TAS 102 in combination with bevacizumab. This is a recent study. Again, this shown benefit. Now, what about re-challenge with the anti-EGFR drugs? There is again data with the cricket study. Even if patients have been previously treated with the anti-EGFR drugs, there is a response, and then you give them a break, you could probably re-challenge with the modest overall response rates and a disease control rate of more than 50%. And similarly, this is the data for panitumumab re-challenge. This is the Chrono study. And you can see here again, the responses are in the tune of 30%, and control of disease, at least of partial response or stable disease of more than at least 4 months is around 63%, which is not too bad in patients with metastatic treatment refractory colorectal cancer. So I think this has been discussed, this algorithm, but mainly to say that in RAS wild type left side, there's no doubt at all. The anti-EGFR is the partner, but on the right side, bevacizumab is the partner drug, but you could use the anti-EGFR if you want a faster, deeper response, especially in patients with high tumor burden. And if the patient has got a MSI high, definitely Pembro. And there is no doubt about RAS mutated, the bevacizumab is a combination. And so is the case with BRAF in a mutation positivity. And of course, the second line would depend on what you have used initially. If you have used anti-EGFR, you could go to anti-angiogenic in the second line. And here, if you have used the bevacizumab initially, you could go for anti-EGFR second line, or you could change the chemotherapy backbone. And if you've used Pembro in the first line, you could use Bev or anti-EGFR depending on the RAS and BRAF status. So in the second line, we have mentioned about all these things based on the markers, the NGS studies. You could probably use any of these. based on the amplification of mutation fusion positivity of NTRK or whichever, and you could also consider second line immunotherapy. So to conclude, in the first line, metastatic colorectal cancer is not one disease definitely, and patient and tumor characteristics have to be considered before embarking on the right treatment. RAS wild type left-sided tumors, absolutely no doubt about it, chemo plus anti-EGFR. RAS wild type right-sided tumors, chemo plus BEV, but anti-EGFR could be considered in case the patient is young and high tumor burden. In these kind of situations, definitely yes. RAS mutated right or left, consider triplet chemo if plus BEV if fit, definitely. But again, it depends on physician discretion what you consider as fit. Of course, the toxicity with triplet is definitely there. MSI high immunotherapy as first line, and consider HER2 testing, especially in patients who are frail. As you see that NCCN guidelines, there is some benefit of using trastuzumab plus base therapy in these situations as well. And second line, of course, you could, based on the Beacon study and other biomarkers like NTRK, again, finances, logistics are definitely a consideration. And this is an interesting molecule mutation markers, I mean, this target. So molecules are coming up in this direction, the KRAS, G12C, and HER2 mutations. And of course, anti-EGFR therapies, re-challenge could also be considered. Thank you so much for a patient listening.
Thank you, Dr. Vishwanath. And now I call upon Dr. Kripa Bajaj for her talk on cancer does not take a day off. So why should CDK inhibitors?
So good afternoon, everyone. Once again, like we are going to discuss regarding CDK4/6 inhibitors, the famous one, the abemaciclib. So, no. So cancer does not take a day off, then why should a CDK4/6 inhibitor? Today is a talk regarding abemaciclib, the three famous trials of abemaciclib. It's a different by design. So how the bench to bedside got progressed, we all know Eli Lilly is the manufacturer of it. It got manufactured in the Spain. And the two criteria for this history is continuous dosing and blood-brain barrier penetration. So potential importance of sustained inhibition is if we sustainedly inhibited, there will be permanent cell cycle arrest, leading to senescence, which make a cancer lack of proliferation. If the short-term inhibition is there will be temporary quiescence will be there, but again, rebound DNA induction will be there. So abemaciclib, it's an ATP competitive CDK4/6 inhibitor. Preferentially, it prefers to inhibit more CDK6 than CDK4. It's almost 14 times preferentially inhibit CDK6. So CDK6 levels, if it is decreased, there will be defects in the hematopoietic system. So the phase 1 study was conducted. Neutropenia was not the low dose-limiting toxicity in spite of CDK6 inhibition. Already mentioned 14 times abemaciclib will inhibit CDK6. But in spite of that, neutropenia was never a dose-limiting toxicity, and continued dosing was feasible. And dose-limiting toxicity was fatigue, or almost all of us have that experience regarding fatigue. That's the only dose-limiting toxicity which was seen in the phase 1 study of abemaciclib. And again, the abemaciclib effectively distributes into the CNS. Functional evidence for CNS penetration by abemaciclib was already there in the mouse model. For intracranial GBM model, their significant penetration was there. It inhibits the growth of intracranial human brain tumor xenografts. So how it got developed? From the late line to midline as well as the early line, Monarch 1, Monarch 2, Monarch 3 got evolved. So what is the Monarch 1 study? This is the first study which got tried in the patients who progressed on multiple lines of therapy with the prior inclusion of endocrine treatment, as well as 1 or 2 chemotherapy regimens as well. So these patients are heavily treated post multiple lines of therapy. And this one, single agent abemaciclib was used, 200 mg BD, continuous dose was used. The primary endpoint was overall response rate, objective response rate. There was significant reduction. That's almost the response was rate was 19.7%. All are PRs. There is stable disease 22.7. So the clinical benefit rate is 42.4%. So all toxicities were tolerable toxicities. Grade 3 toxicities are significantly low, but grade 1, grade 2 are high. Overall, it can be tolerated. The summary of the study is phase 1 clinical study demonstrated a safety clinical profile of abemaciclib, which allows continuous dosing. While neutropenia occurred, it was not the dose-limiting toxicity. Monarch 1 results at the 12-month final analysis, the primary objective of confirmed objective response rate was 19.7 months, but clinical benefit rate, including stable disease, it is 42.4 months, which is really good in a patients who got heavily treated prior. And the median PFS was 6 months and median overall survival was 17.7 months. Abemaciclib is the only CDK4/6 inhibitor as of now, which is can be used as a monotherapy and which can cross blood-brain barrier. The survival benefit with abemaciclib, Monarch 2. This is a randomized double-blind placebo-controlled phase 3 study of fulvestrant with or without abemaciclib. This is post 1 line of endocrine therapy prior in the metastatic breast cancer setting. It's post letrozole. So patients who are relapsed on neoadjuvant or adjuvant setting who are resistant to endocrine therapy, either primary or secondary endocrine resistance, both pre and peri and post-menopausal, all patients got included. This patients progress from first-line ET in the metastatic breast cancer. Adjuvant is like different, but metastatic, it's second-line therapy. So in this one, patient got randomized to abema plus fulvestrant. Abema dose here is 150 mg BD versus placebo plus fulvestrant. We all know once patient progressed on AS, the next default choice for us is fulvestrant if patient is not affordable for CDK4/6 inhibitor. And the endpoints are PFS as well as OS. So this is the ET resistance. All know it is very difficult to treat primary endocrine resistant breast cancers. The distribution here is almost 25% of the patients are primary endocrine resistant and 75% nearly are secondary endocrine resistant. So the patients who are PR negative, it's emerging as a prognostic factor. The primary endocrine resistance, PR negativity, and significant visceral disease. These three are the very significantly known prognostic factors. In this one, the visceral disease consists of 60% of the patients, PR negativity, 20% of the patients, and premenopausal and perimenopausal, it's only 16% of the patients. So if you see the median PFS in the second line metastatic breast cancer setting is 16.4 months versus 9.3 months, which is significant. We see all groups got benefited, including the poor prognosis group like primary endocrine resistance and secondary endocrine resistance. If you see the primary endocrine resistance is still towards too much to the favoring abemaciclib, and PR negativity and visceral disease, there is a good benefit got noted, which was disproportionate to the prior trials or prior regimens. We see the overall response rate is 35.2% in measurable disease and 72.2% overall. The clinical benefit rate is very high. Compared to the placebo, it is only 56.1%. It's almost double. So the updated PFS interim at 36 months is 30% versus 10%, which is really significant. Almost tripling of the PFS got noted. The OS again, 9.47 months benefit is there. Very few drugs can provide 9.47 months. We saw the palbociclib data recently. There is no OS advantage, but definitely palbo and abema efficacy comparison, OS wise, abema scored really well in second line. 9.47 months benefit is significant. So OS stratification again, primary endocrine resistance and visceral disease is significant. The site of metastasis predominantly are lung, liver, pleura, and endocrine resistance. I already know, all of you know the primary is the patients who relapsed while on first 2 years of adjuvant endocrine therapy are PD within the first 6 months of therapy in the first line metastatic setting. So in these groups as well, there is a significant benefit is there, which was not expected with this. By metastatic site, visceral, bone, as well as other, all patients got a good benefit, but visceral hazard ratio is significantly better. It is 0.675. And primary endocrine resistance and secondary endocrine resistance, we see their curves, initially they are not separable much, but eventually they got separated with hazard ratio 0.78. If you see the primary endocrine resistance, the curves are rightly separated from the very beginning with hazard ratio of 0.686, suggesting primary endocrine resistant patients do have very good benefit with abemaciclib. And again, the exploratory endpoint, time to chemotherapy. The time to chemotherapy, again, is significantly better, 50.2 months versus 22.1 months. So again, treatment emergent adverse events, the grade 3 events are significantly low. Though the all grades, if you see, it's the numbers are staggering, but grade 3 is significantly low, suggesting a tolerability. What are the conclusions of Monarch 2? The addition of abemaciclib to fulvestrant provided a statistically significant overall survival improvement in patients with HR positive, HER2 negative advanced breast cancer who progressed on prior ET. The median OS benefit is 9.4 months, which is significant. OS benefit was consistent across subgroups, including patients with poor prognostic factors such as visceral metastasis and primary ET resistance. After median follow-up of 47.7 months, 17% of patients in the abemaciclib arm remained on treatment versus 4% only in placebo arm. After median follow-up of 47.7 months, abemaciclib significantly delayed the receipt of subsequent chemotherapy in exploratory analysis. And again, Monarch 3, most of us are practicing CDK4/6 inhibitor in the upfront setting because patients are likely affordable with a very good patient support program. So Monarch 3, abemaciclib as initial therapy for advanced breast cancer. If you see the Monarch 3 study, postmenopausal patients got included who received neoadjuvant or adjuvant endocrine therapy, but not a first-line therapy in the metastatic setting. It's a first-line therapy in a Monarch 3, included abemaciclib plus anazole letrozole versus letrozole alone with placebo. Primary endpoint is PFS, secondary endpoint is OS. If you see here, there is significant improvement in median PFS versus placebo plus NSAI as initial endocrine therapy, that is 28.2 months versus 14.8 months, near doubling got noted. And again, significant improvement in PFS as initial endocrine therapy, longer follow-up got noted, that is 28.2 versus 14.8. And all subsets got a very good benefit. Here, there is nothing like primary versus secondary, but visceral metastasis patients, everyone got a significant benefit in the first line compared to NSA alone. The response rate, the change in tumor size was significant. The clinical benefit rate is 78% compared to the 71%, almost 7% difference is there. We all choose to give letrozole alone in the first line prior, but CDK4/6 inhibitors change our perspective regarding the management. And abemaciclib plus NSA again demonstrated consistent PFS in women with liver metastasis. We all know liver metastasis patients do fairly low. There is a PFS benefit almost double, 15 months versus 7.2 months. Again, showing the with a very good benefit of abemaciclib in the first line with hazard ratio 0.477. Change in tumor size by cycle, responses observed in patients who received abemaciclib generally occurred very early. If you see, the curve started separating very early and it maintained across with a very good response. Adverse events, again, they're manageable. The grade 3 adverse events are like slightly high, but they're comparable and manageable. What are the Monarch 3 conclusion? Abemaciclib plus NSA significantly improved PFS and overall response rate as initial therapy in hormone receptor positive advanced breast cancer in postmenopausal patients. Benefit from abemaciclib plus NSA was consistent across pre-planned subgroups. Response observed in patients who received Ramivan generally occurred early and they were maintained on time and led to substantial tumor shrinkage. Abemaciclib in combination with NSA was generally well tolerated and the safety profile was consistent with other abemaciclib studies. Thanks for the Eli Lilly for this opportunity and management group for giving this opportunity. Any questions are happily taken. If there is no questions, I conclude this study.
Yeah. Thank you. Okay. So, sir, for like is what
Thank you so very much, Shikha. And it makes me more humble, the way you've greeted me after so many years. Good afternoon, everyone. I'm Dr. Uttam Soni. I'm a consultant oncoplastic breast surgeon, and why I'm standing is to talk and discuss about TVADs. TVADs is totally implantable venous access devices. Why we use it, where we use it, and what can happen with TVADs. This is a disclaimer. So we are concerned about cancer only because this is precision oncology.
For treatment of cancer, we have traditional cancer therapy, which includes chemotherapy, radiotherapy, and surgery, individually, mixed, or a multimodal approach. And chemotherapy approach with various protocols delivered according to the age, weight, and height of the patient. Patterns depends on the type of cancer. Generally given in combination therapy, we use single therapies as well, minimum for 6 to 8 months. Now, these agents which are used for chemotherapy, they are highly toxic, vesicant, and irritant drugs, and that's why we call them cytotoxic drugs. And these are adriamycin, Taxol, cisplatin, methotrexate, and Christine, vinblastine. So these are more vesicant and toxic drugs. They infuse slowly over a period of time. They interact with the vessel wall, cause inflammation and complication, and that's why we need a CVAD or a TVAD, because we bypass the peripheral vascular system. Now, besides chemotherapy, we can use them for TPNs and PPNs, for intermittent drugs, for general IV medications, infusion of drugs through pressure pumps, blood sampling, and blood products as well. What is a CVAD? CVAD is an implanted or indwelling biocompatible device used for administration of therapeutic substance agents into central venous system or arterial and hepatic system as well. Now, what are the common veins that we access with CVADs or TVADs? Common ones are subclavian, jugular, basilic, and cephalic. Nowadays, we are moving more on to jugular system because we can actually have a continuous image access while we are putting that port or venous access device in. It is easy to approach. Types, now they are long-term, short-term, and intermediate term. For short-term, which is from 7 to 10 days, intermediate 1 to 2 months, and long-term is 1 year and above. Short-term, we have Cavafix, AeroCook, the normal, central lines. For intermediate, we use Hones and PIC line that is commonly used. And for long-term, we can use PIC line also for long-term with Hickman and chemoports. Now, implantable subcutaneous port into venous, arterial, epidural, or peritoneal system with open-ended or valve catheter. This is how we use, or this is how they are available. Now, what is a port? It is a device which is totally implantable into central venous system. So nothing is visible outside your body. Everything is inside the body, and the port itself is placed subcutaneously into your chest wall or into the arm. It is a sure and safe venous access with minimal maintenance. And I can say almost zero maintenance now. So this is PortaCath system, wherein you can see the catheter going into subclavian, and then we have this button which is known as PortaCath implanted into the chest wall. Everything subcutaneous. Various types of ports available. We have a plethora of ports availability, but normally what we use, or which is commonly used, is a Grosjean catheter with an MRI compatible PortaCath. The second one, you can see the second one. Different type of products, as I've told you, slim ports, which are low profile ports normally used for kids and lean patients. We can implant these ports both in arm as well as chest wall, and they're available with 6 French catheter. Export, now this is a new addition wherein we can use it with pressure as well, with dyes, blood products, anything which is needed, any drug which is to be delivered with pressure as well. This is the highest quality. ISP port that I was talking about, this is MRI compatible port, maximally used now. Again, power ports, which are coming up in a, in a big manner now. So these are the accessories which actually comes in with a venous access device or a chemoport. We have special infusion needles, which are known as winged infusion sets or Huber needle. These are non-coring needles. Non-coring means whenever a needle goes into a septum, it actually takes a piece of it with it. So if the septum is silicone, so if we are using normal needles, they will carry a piece of it with it. And by mistake, if it goes into circulation, that can cause problem. So we use special needles, which are non-coring needles, which actually go inside the septum without cutting it. Non-coring, they don't cut a core out of it. So this is winged infusion set or Huber needle. Then we have special introducers, peel apart introducers, and tunnelers. Multiple companies, they come up with chemoports. We are here because BD, otherwise the lunch won't be there, BD. They're placed in IR or OR. We prefer them doing it into OR because it has to be very sterile. There are several complications which can happen, for which we have to reduce the chances, and the best place is an OR. It may be used for chemo same day if it is inserted. So we use it in the same manner. We do it in the morning, and by afternoon, the patient is ready for chemo. They need Huber. We talk about that Huber needle. One septum or one port actually allows us to do sterile procedures for 2000 punches. The 2000 punches is huge. We normally don't use them for this much, but they are made that if required, we can use them for 2000 punches. It is nice venous device for patient, low care, low maintenance. As I told you, the new catheter that we are using is valved Grosjean catheter, which does not need any maintenance at all. It needs flush once a month. This is open-ended catheter. A Grosjean catheter needs flushing once in 6 months. When not to do a chemoport, when not to do a venous access device. So when there's presence of device-related infection, the patient already have infected area, bacteremia or septicemia, or is suspected to have that. When the patient's body size is insufficient for the size of implanted device, very small people, very lean people, we avoid doing that. It is known when the patient is known or suspected to be allergic to materials contained in the device. So if any of the device patient is allergic to, we avoid doing it. If there is severe chronic obstructive lung disease, because it is very difficult for that patient to lie down straight, and we can have problems. If the prospective insertion device has been previously irradiated, if we have irradiated that site earlier, then that is not a good place to put your venous access device. It is a contraindication, absolute contraindication, unless we don't have any other place available. If the prospective placement site has previously suffered episodes of venous thrombosis, if we are using a venous channel and that has episodes of thrombosis in past, we need to avoid it because that can cause further problems. If local tissue factors will prevent proper device stabilization or access. So most of these contraindications are related to the local sites. Even I can go wrong. So why I put this, even I can go wrong, because I've done more than 3000 ports till now. And these are the complications which I have seen. Air embolism, bleeding, brachial plexus injury, cardiac arrhythmias, tamponades, catheter port erosion through the skin, catheter embolism, catheter occlusion, damage, breakage due to compression between clavicle and first rib, catheter or port-related sepsis, device rotation, extrusion, endocarditis, extravasation, anything. Whatever is written in book, it can happen. And whatever is not written can also happen. So be very cautious. Learn from what your trainer is telling you. Don't be overconfident. So I've done 3000. Now I'm more fearful. Whenever I do a chemoport, I have a team now. So I used to do it with 2 or 3 people. Now we have 10. We do it with a team of 10 persons. And then we can have complications like fibrin sheath formation, hematomas, hemothorax, hydrothorax, intolerance reaction to implanted device, inflammation, necrosis, scarring, laceration of vessels or viscous, perforation of vessels or viscous, pneumothorax, spontaneous catheter malposition or retraction, thoracic duct injury, thromboembolism, vascular thrombosis, vessel erosion. And I've recently heard of one more complication, and that is migration of the guide wire into the cardiac chamber. Again, difficult, you are there and to put a venous access device, and suddenly you come out and you say to the family, patient ko cardiac center le jana padega. So we have to be very careful when we're doing it. It is a matter of 20 minutes only. If you're doing it with the right people, you can do it in 20 minutes. But if in case you miss it, it's gone. 2, 3, 4 days. Although, all of these things are manageable, but if you are more careful to start with, why to land in problem first? So this is type of occlusion that we can have. Normally they happen with open-ended catheters. Since we have started using a valved Grosjean catheter, we have not faced these problems. So intraluminal, within the lumen of the catheter, fibrin tail at the end of the catheter, mural thrombus, and fibrin sheath. Now these are different type of occlusions that we can have. Fibrin clot. Now this is a normal physiological response, but if it is not taken care of, your venous access device can become non-functional, and it is a costly affair. So the cost of the venous access device itself, plus the amount that you actually given for the patient is giving for implanting it, it is huge. So we just need to make justice to that, and we have to be very careful in maintaining it as well. Fibrin sheath in the retrograde flow, again, a complication of occlusion. Port thrombus. So what happens is we use the port to aspirate blood as well. Now, this is a chamber, and if in case it is not washed properly and the blood stays in there, it will clot. If it clot, it forms a thrombus. If it forms a thrombus, it occludes. And there is no way that you can actually clear it off now. People try everything, streptokinase, urokinase, but it is very difficult. So at the first thing, why to let it happen? If you are aspirating blood, wash it properly with NS. That is it. 20 cc of NS is required to wash it properly. Do that. Port pocket infection. Now there are two ways of getting it. One is if you are doing it and you're not doing it in a completely sterile environment. So whenever you're doing a chemo port placement, you have to make sure that you're doing it in the same manner as you're doing any, implant in your body. So all implants have to be taken and dealt with in the same sterile manner. So first fault is at the place where you're doing it. And second is because it is used multiple times, it is used, every week or 2 weeks or 3 weeks, the team who's dealing with this, your nursing staff, they should know how to deal with it. If they are not using proper asepsis, they can always introduce infection from the skin into the catheter, into the port, and then into the catheter. And take it, my words, this catheter is going on the top of your heart. So once you get an infection, it is like, very difficult to clear off. Tip malposition. So can anyone see the tip out here, tip of the catheter in this picture? Can anyone see? दिख रहा है किसी को? You can see that? You can see that? No, I'm not talking to you. You sit down. You raise your hands, yes? Come up. आ जाओ. अरे ज्यादा गलत ही तो होंगे. Come in. Show me where it is. Show me. Come up. Mark it. What's your name? What do you do? DM resident for what? Medical oncology. Good. Show me that. Show. Mark it on the board. Do it. You're right. You're absolutely right. So how this has happened is the patient coughed. And with the severe cough, a properly planted catheter just changed everything. It got itself malpositioned. And how do you come to know? It was an accidental X-ray done because the catheter is still in the venous system, but is now not in the right position. It is in the wrong position where it can cause thrombosis. How do you treat it? So if you see a picture like this, what will you do? It has to come out. You cannot correct it. If this is the picture, the port needs to come out. Catheter pinch off. So this is a phenomena which normally happens with subclavian catheter positioning. The subclavian vein lies between the first rib and the clavicle, and the space is very small. There's a lot of pressure from the clavicle on the first rib. So you've inserted your catheter in, but the catheter is in a small space. The venous system is pinched by first rib and the clavicle. So what will happen is, over a period of time, this place will get weak and highly susceptible to a fracture of the catheter. So this position comes in when you try to remove the catheter after a certain period of time. And what will happen is, this place will fracture. So the part which is proximal to this place will come out with you. You are happy, catheter nikal diya, port nikal diya. But the part distal to this is still lying hanging. The proximal tip of this broken catheter is pinched between first rib and clavicle, and the distal part is lying where it is already. If you see the picture again, and you see a catheter coming down wherein you don't have a proximal end, what will you do? Again, the cardiologist, they will take care of it. They'll snare it out. But this is a complication. And if it is a complication which is bound to happen in 2 out of 20 patients, why to choose that route? So we have changed ourselves from subclavian to internal jugular now, wherein we try to avoid this thing. Port erosion through the skin. So if the subcutaneous fat is less, or you have actually dissected the port site or the port pocket in such a manner that you've taken most of the subcutaneous fat as well, what will happen is the port will give more pressure on the skin, subsequently eroding through it. We need to be very cautious about this. We try to salvage these things. If it's not infected, we try to salvage it. We take the help of plastic surgeons. They put in some flaps or cover it, and till the time the chemotherapy is delivered, we just try to maintain it. But if it gets infected, we need to take it out. Chemo extravasation. Again, if the catheter gets fractured, I'm the last one, yeah. So if the catheter gets fractured, you can have chemotherapy extravasation there. If the needle is not put in properly into the port, we can have extravasation. There is one more important site, the place where the catheter goes inside the neck vein. If you are holding the catheter with traumatic forceps, you won't know, but you have actually injured the catheter. And this is a blunder, because you are doing everything to facilitate the life of the patient. And if this handling is poor and patient gets these injuries into the catheter, ultimately what happens is chemo extravasation, and they can have severe reactions in the skin. Need to avoid it. That's how it happens. How do you select a venous access device? Depending on how long you'll need it. So the questions that we need to ask is how long the venous access device would be needed, which medications needs to be given, which insertion site would be used. So if we are operating on a breast cancer patient on a left side, I'll use a right internal jugular. If I'm operating on the right side, I use a left internal jugular. Safety, how independent the VA will let them to be, how easy it would be to take care of, and do we teach the patient what they need or what do we think they need? We have to make them very much aware of what a port is. Thank you.
On behalf of Precision Oncology, I thank all the faculties, residents, pharma companies, and event team for sparing their valuable time and joining us here in this conference and making this conference a memorable and successful one. It's a proud privilege to announce about our upcoming IBCC conference, which we are planning to be in second week of November. I extend my warm invitation to all of you on behalf of IBCC. Hope to see all of you in that conference. Thank you.
There's one more announcement that I need to make. So we are actually planning a series of chemo port placement workshops at a center where we're doing it. This is absolutely free of cost for trainees, maximum number of 10, and that starts from second week of August this year. This is going to be an interactive workshop wherein you will learn about the theory and the practical aspects of chemo port placement, how to maintain them. And if people are interested with surgical disciplines, they'll get some hands-on as well. Thank you.
We'll be having live workshop on Tuesday only of chemo port placement. So anybody interested can join us also.